Good afternoon, everyone. It gives me a great pleasure inviting you to this plenary on AML that we are about to start. So thanks everybody for settling in. My name is Ashish Vejal. I am a hematologist and transplant physician from the Peter MacCallum Cancer Centre and the Royal Melbourne Hospital, Melbourne, Australia. And my co-chair is Professor Kim Hee-ji, who's from the Catholic University of Korea and the St. Mary's Hospital, Seoul, Korea. So I'll just hand over to Dr. Kim to start introducing our first plenary speaker for the day.
Okay, I think you know very well him, but anyway, I'll briefly introduce Dr. Mark Levis. He's from Maryland, Baltimore, USA, Johns Hopkins University, professor of oncology and pharmacology at Johns Hopkins University School of Medicine. Dr. Levis also co-director of the hematology malignancies and bone marrow transplantation program, and leads the adult leukemia service at the Sydney Kimmel Cancer Center. He's also a physician scientist with expertise in AML and CML, ALL, and MDS. He has advanced translational leukemia research and clinical innovation. He also trained further leaders through the Johns Hopkins graduate program in cellular and molecular medicine. So would you welcome Dr. Mark Levis?
Yeah, I got to figure this thing out. It's been a challenge, I guess. I certainly want to thank the organizers for the invitation to this fascinating meeting in this very interesting city. Maybe that. There we go. So I was asked to talk about, first I'll step back, integrating novel agents into the frontline management of AML. And I don't think this is an easy problem. It's a good problem to have. I'll just shout from here. Why is it not an easy problem? Okay, the disease is complex. Everyone in the room knows this. It arises out of successive mutations within stem progenitor cells. And there's a lot of mutations to choose from. And when they present, a patient already has polyclonal disease. You think it's safe? Okay. The patients already have polyclonal disease. And they'll have a founder mutation, but already cooperating mutations differ at presentation. And looking at these sort of phylogenetic maps of AML, when a patient presents, you can kind of trace it back, but the mixture of clones, subclones within a patient's bone marrow illustrates the complexity of what we're dealing with different mutations. And if we're going to somehow use our targeted agents against these, well, they're only going to work against some subtypes or some subpopulations. You almost look at AML now like a population biologist. And so when a patient presents, they've got different clones competing with each other. And at presentation, the winning clone did so without any therapy. Now, if you apply a therapy to that, the environment changes and the competition changes. So you have a patient diagnosed with AML. Nowadays, we get to decide between aza-ven and or HMA-ven and intensive induction, where at my institution, we're leaning more and more towards the aza-ven. I think that's a worldwide phenomenon. We keep coming up with excuses for why somebody's not fit. And so we get a complete remission. Okay, I've got one patient who's getting aza-ven for 6 years. I've spaced out the treatments, but I'm like, it's time to stop, lady. I don't know what to do here. Intensive consolidation. Maybe we'll just lose our nerve and transplant the patient. What do we do then? We can give them maintenance either in the non-transplant setting or the post-transplant setting. And all of these are, how do we mix these targeted agents together? This is not an easy problem. A wonderful new toy that's emerging is measurable residual disease. So we have to now use this as we're deciding which targeted agents to use and when. All right, flow cytometry, cell-based. RNA-based is the RT-PCR, and then there's DNA-based. Now, the flow cytometry is technically applicable to all subtypes. The problem is AML will change its phenotype routinely. It's devilishly difficult to get this to be reliable and standardized, despite what anybody has said. So I still think this one is going to eventually go away. RNA-based techniques are applicable to specific subtypes, and while that's a pretty good fraction of them, that amounts to getting close to half of all AML. RNA is still problematic. It is unstable. Patients have to have it drawn just so, and it's got to get to the lab just so. But nonetheless, we're still using it. The DNA-based approaches, I think, are emerging and technically might apply to all subtypes. But these are emerging methodologies, one of which is this MRD assay for FLT3 IDD mutations, which, when you at least compare it to an RNA-based or a flow cytometry-based assay, seems to be superior, although it's focused on one specific mutation, one specific subtype, but it literally outperforms. In fact, in this study out of the HOVON, multi-parameter flow cytometry added literally nothing to the prognostic power of this DNA-based assay. The RNA-based NPM1 added a little bit, but really this outperformed both. And if I had to guess from what I have seen going on in the field right now, 5 years from now, MRD is going to be DNA-based, cell-free DNA. We're going to get away from these stupid bone marrows and arguing about whether to use peripheral blood or bone marrow. And I suspect this is where we'll be in 5 years. And it's going to be more accurate, far easier to do. And of course, if we can do it cheaply enough, you can literally do this rather than a CBC. Future, maybe. All right, so now we have to incorporate all these wonderful targeted therapies. And we already know that incorporating targeted therapies into standard therapy right now has led to significant benefits. Gemtuzumab, I think the biggest benefit is in core binding factor, but it clearly changed at my institution. Our survival just went up, in a very measurable way. I think these are real data. Everybody knows APL. That's, we pretty much only use arsenic and ATRA to treat that disease. We don't use chemotherapy at my institution at all anymore. And BCL2 inhibition has been an enormous change in AML, as you all know, incorporated into an AZA backbone. Okay, we've got a lot of targets now, and they keep emerging. We've got FLT3, and there's 4 different FLT3 inhibitors running around the world. We've got KMT2A fusions and NPM1 mutations that are now being targeted by menin inhibitors. Revumenib has already got an FDA label, and there are several other menin inhibitors hot on its tail. Enasidenib for IDH2, 2 different IDH1 inhibitors, and our BCL2 inhibitor. And there's going to be more versions of both against these targets, and presumably some new targets emerging. I would love to see RUNX1 targeted. So this is a very partial list of different trials exploring the incorporation of these agents into standard backbones. So look at, we have, of course, the Ratify trial. Way back when, that was 8 years ago, a FLT3 inhibitor with intensive therapy. Then we had the BCL2 inhibitor with azacitidine. We have FLT3 inhibitors for post-transplant maintenance. Quite a few studies looking at this. Sorafenib, gilteritinib, even quizartinib now. 7+3 plus of IDH1 or 2 inhibitor. Again, we don't have randomized data, but the randomized data are going to be emerging for this very short. Azacitidine and ivosidenib. Randomized data demonstrating this is a tremendously effective combination. Very easy to give to older patients. Enasidenib. We did a trial of post-transplant maintenance for IDH2 mutated, and IVO for post-transplant maintenance for IDH1. Again, these are not randomized, but the randomized study run out of the HOVON does allow for these drugs after transplant. So then you have the latest FLT3 inhibitor with intensive therapy. Oh, let's go to AZA-VEN as our backbone and add another FLT3 inhibitor. This is AZA-VEN-GILT for FLT3 mutated AML. Or we can do AZA-VEN and an IDH1 or a 2 inhibitor, or we can finally, not to be left behind, all the menin inhibitors. Right now, we're literally using in trials AZA-VEN plus a menin inhibitor. Incredibly effective, well-tolerated therapy. So as we're planning to do all this, there's a few things to ponder. First of all, when there's more than one target, do we combine or do we sequence? And this is a big deal because you've got this problem of overlapping toxicities. Now, what I'm already facing, and I'm going to give some case examples, how long are we supposed to use these drugs? When you all remember when TKIs came out for Philadelphia chromosome-driven disease, we thought the patients would be on them for years, and we've had patients on them for literally, I've had some on for decades, but we're able to stop these drugs now, again, using MRD techniques, usually. And finally, pharmacokinetics. So I did my PhD in a pharmacology lab, and I go back to PK all the time. Drug-drug interactions between the targeted agents. We all love to give posaconazole. Problem is, that interacts with all these drugs. So here's an interesting point about pharmacokinetics. Now, many of you have probably seen these curves. This is venetoclax, okay. On the left here, you give venetoclax with azacitidine, you give a dose, the level goes up and it comes down. Isn't that nice? And this is at steady state. And then venetoclax with posaconazole, well, if you give just a mere 50 milligrams of venetoclax with posa, you get almost the same level as venetoclax 400 alone. That was based on 12 patients. Okay. Now, the other thing you'll note from these curves, and I'm always amused when I see a PK publication, look at those error bars. And some of those are actually standard error of the mean. They're totally cheating statistically. The actual study is this. And what you see here, every little dot is an individual level. And so you're telling me that those patients down at the bottom, you think you need to dose reduce them? That's a fast metabolizer. You dose reduce, you're taking the drug that led to the biggest advance in survival in AML we've seen in years and taking it away because you want to give posaconazole. Or you think you can do it accurately. I would argue you cannot. You would have no means of doing this accurately with that enormous interpatient variability. This is very typical, of a CYP3A4 metabolized drug. And most of these drugs do this. Mind you, if you give ivosidenib will decrease the level of ven. At least those are preliminary data. It's not predictable. And it's very common. This is gilteritinib. Steady state, 120 milligrams. Look at that enormous interpatient variability. You really think you can accurately combine these two drugs for everybody? There's no way you're going to be able to do that. The data needs to be much more personalized. And this is one of the reasons I tend to argue for sequencing rather than combining. But you can't always do that. You can take a look at overlapping toxicities and help guide that. So what I'm going to do now, still want louder, eh? Okay. Yeah, but it screamed at me before. All right. What I'm going to do now is share some cases from my clinic. And I recognize that throughout the world, you don't have access necessarily to all these drugs and all these indications and all these tools. I will readily state I do. I literally have access to just about everything we've set up here, and I can almost give it however I want. That would be one reason why our healthcare system in the US is collapsing and why our government has shut down in an argument over this. So I'm responsible for this. But nonetheless, I'm going to do this for my patients until they stop me. So here we have a 71-year-old woman, and this was from a few years ago. So she's morbidly obese. There's a common problem in the US. BMI 42. That is not uncommon, unfortunately. Hypertension. And she shows up with 3 weeks of feeling badly, shows up to the ER, and she's got a high white blood cell count, creatinine 1.7, and we didn't bother with a bone marrow biopsy, flow cytometry, AML. So, okay, there's her flow. And so here we have this acute kidney injury, and she's in leukostasis. She's not quite mentating right, a little gaspy, you know the look. Doesn't look good. Okay, what am I going to do with this lady? I'm not even sure how well she's going to swallow her hydrea. So we actually give a single dose of gemtuzumab. I can get away with that. Works great. I didn't want to give her cytarabine. She doesn't have a very good kidney and she's 71. How am I going to reduce this? So we got a very rapid cytoreduction, and then I started aza-ven shortly thereafter. Here's her white count curve. You can see how rapidly the single dose, one vial, 4.5 milligrams, everything just drifts away. She woke up, got better. I didn't have to give her a week of Hydrea to get that count down. I agree it's cheating, but in fact, that's what I can do. I then gave her aza-ven. And so she's, here she is, cytoreduced, now on aza-ven. And, her NGS results came back because it still takes us 1 to 2 weeks to get those things back. And she's got a FLT3 D835Y, pretty decent VAF, IDH1, R132H, and an NPM1. I can work with that. So she's had aza-ven, and her blood counts a mere 6 weeks after her showing up in leukostasis are this: virtually normal, feels well, walking around. She spent 2 weeks in the hospital and got out. Okay, I did a bone marrow biopsy, and she has no evidence of disease. You always want to look in the central nervous system with a FLT3 patient. They have a lot of occult disease. And so I switched her now. She's got an IDH1, and she's still who she is. I'm going to move her to a gentler therapy. I moved her to aza-ivo, a published regimen. Okay, let's start that. So we're back. This is 3 years ago. And so I gave her the aza-ivo, left her on ivosidenib, because ivosidenib is the best tolerated, most incredible agent you've ever worked with. It doesn't do anything harmful to anybody, and yet it will often give very durable responses. Great drug. Okay, so here's to summarize her. I want to deal with that FLT3. So I popped her on gilteritinib, 120. And she remains on the dual targeted therapy, ivosidenib 500 a day, gilteritinib 120 a day. I checked her at 9 months, no evidence of AML, and furthermore, she's got an NPM1. I can follow that. So she's MRD negative at 9 months. So to summarize, starting October 22, I repeated the marrow again. She grumbled, but she was MRD negative in her marrow, 24, more than a year out. And I just saw her in clinic. She's still on her 2 drugs. Now, my next decision is, when do I stop and what do I stop? And I don't know. And I will grant you that we don't have the data to tell me what to do, but I had a morbidly obese 71-year-old showing up in leukostasis 3 years ago, and I popped her on 2 pills. She spent 2 weeks in the hospital. She's been totally normal since that time. This is one of the things you can do with targeted therapy. All right. So what do we do with these unfit patients? This is a big issue, and particularly the FLT3 mutated ones. We know aza and ven together is less effective for the FLT3 mutated patients. They'll go into remission, like my patient did, but quickly relapse if you don't do something. And that's why I put her on gilteritinib. So should we add a FLT3 inhibitor to aza-ven? Well, the problem with doing that is this is hematopoiesis, and the green, all the cells inside the green boundary there express FLT3, the wild type FLT3. And FLT3 is incredibly important for reestablishing hematopoiesis after aplasia, for example. And the cell that really is doing it, is expressing large amounts of FLT3, is this multipotent progenitor cell. And the multipotent progenitor cell is dependent upon BCL2 and MCL1 via FLT3. So if you inhibit FLT3 and BCL2, you are going to seriously impede this cell. And this is why you get the aplasias that you see with this. And so while giving the triplet aza-ven-gilt is very effective, these are FLT3 ITD MRD results from patients on the study. Look how they go down with each cycle. The problem is it's very myelosuppressive, and doing that to somebody, that older patient population, is tough to do. They have a median time of recovery of 40 days. That looks like 7 + 3 worse. And so, yes, they have to take a bone marrow biopsy on day 14. This looks like 7 and 3 to me. And there is an ongoing phase 2 trial. I do use this regimen, but I typically reserve it for salvage or desperation. I don't tend to give it up front. I don't need to, usually. All right, now 65-year-old woman. So this is, she's recently retired, very good performance status, but the problem is she came in with this very funny history that I don't think any of you will have heard of. We certainly hadn't heard of it. She has benign recurrent intrahepatic cholestasis. It's a real thing. We looked it up. It makes this lady become jaundiced intermittently if you give her drugs. And so we stood around and said, well, we're not giving her 7 and 3. What should we do? But unfortunately, she had the usual symptoms of dyspnea, gum swelling, a complete blood count. Here she comes with AML. And we did a biopsy, and it's AML. Okay, dearie me. So she had a normal karyotype. We kind of waited until we got her genetics back. We were very nervous about this lady because we didn't know about what to make of this benign recurrent thing. And she had a FLT3 ITD. That came back first by PCR. And here's her NGS. So she's got a DNMT3A, NPM1, FLT3 ITD. This is a very common mutation combo. About 5% of all AMLs got this. Okay, that's trouble. She's got a few other founder mutations in there. It's complex, but what do we do? All right, so, well, we'll give her azaven and see what happens. We gave her azaven, and yes, she had liver enzymes go up, but it really wasn't bad. And her counts recovered on day 42, no increased blasts. And so we said, okay, we'll start her on cycle 2 azaven. And by this time, I've decided I'm going to transplant her. She's fit enough. I don't care about this, whatever this benign recurrent thing is. I bet I can get away with a transplant here. So she didn't have any siblings or children. We usually prefer using haplo children, but as donors, but she didn't have any relatives that we could go after. So we found an unrelated donor. And after she's had 2 cycles of azaven and is in remission, I just popped her on gilteritinib and said, stay there until I get your transplant lined up, which is a very common approach that I use. And again, this is sequence rather than simultaneous. So, and she was in the hospital only briefly. I mean, it was again about 10 days and then out. That's it. All right, so pre-transplant, she's free of any evidence of AML, and great, counts look okay. But here's my MRD assay. Ooh, that thing is not very deep at all. It's sitting right there. There's her 21 base pair 21 base pair FLT3 right there. She's in a morphologic remission, but this is, waiting to relapse. All right, so we went ahead with the transplant. Yes, there were liver enzyme problems, but they really were transient. And we used PBSCs from her donor, post-transplant Cy, like we do at Hopkins. And I put her on gilteritinib because I knew that monster was there at a high level, day 39, while she was still on tacrolimus. We know from the Morpho study that while overall it was negative, the patients who were MRD positive going into transplant or in the peri-transplant setting were clearly benefiting from gilteritinib. So clearly she's in the population that needs to go on the drug. And so I stopped her tacro on day 60. And by day 100, checked her bone marrow, still a few liver enzyme issues, but they were pretty not terrible, and no evidence of AML. And she had 100% donor chimerism. And unfortunately, my MRD assay didn't get sent. I went and had words with the technicians, but that got screwed up. Welcome to the real world. I said, lady, you need another biopsy. We're going to get one real soon because I don't know where this monster is. And I increased her dose to 120. And 6 months post-transplant, she missed the appointment for the biopsy. I still do not have an MRD assay on her. Oh dear, I'm getting very nervous. And so wait a minute. So her counts are good. And so I'll point out that the dendritic cell is the one mature cell that expresses wild type FLT3. And it actually plays a role in GVH and GVL, we think. So if you stimulate FLT3 by FLT3 ligand, you cause an increase in dendritic cells. If you cause an increase in dendritic cells, they in turn increase Tregs. And Tregs suppress GVL, GVH, we think. Opposite, when you inhibit FLT3, you decrease those dendritic cells. You decrease Tregs, and we will see this when you start a FLT3 inhibitor, you can flare graft versus host disease. And this was seen in the randomized studies. There was always an increase in chronic GVHD, except the study out of Guangzhou. And they used sorafenib. They only had it by protocol for 6 months, but if you look at the protocol, and I met with them earlier this year, They only gave the drug for about 3-4 months, not long enough to actually get chronic GVHD. So she continues on Gilt 120, and she gets chronic graft versus host disease. Oh, bummer. She's got the usual symptoms. Not terrible. I treated her with with topical therapies, and I was like, can I stop the Gilt? Have I cleared the MRD? I said, lady, you really have to come in and get your marrow. And so 9 months after transplant, we get the bone marrow biopsy, morphologically clear, but there's the monster. So it's below the chairs for those of you who can't see, 6 times 10 to the minus 6, 21 base pair. So again, that's the fingerprint. That's the ITD that she presented with. It's still there. Oh dear, what do I do? Well, certainly stay on gilteritinib. Sorry, lady, I can't stop your gilt even though you have GVHD. All right, maybe let's see what happens over time. Oh dear, it's starting to rise. 3 times 0.4 times 10 to the minus 5. It's gone up 5-fold. That's bad. What do I do? She has persistent MRD. I know, I'll use a more potent FLT3 inhibitor. This works every time. Quizartinib. Unfortunately, quizartinib inhibits wild-type FLT3 more potently than Gilt. I got worse GVH instantly. She came in howling. Her mouth was ready to fall off. Oh, sorry, lady. We'll stop the quiz and go back to Gilt. So we did that, and I got her GVHD. She still has an ugly mouth, but she put her on dexamethasone mouth rinse. That was fine. All right. 21 months out, let's reassess. Still in remission. So all this time, she's in morphologic remission. Oh dear, 8.7 times 10 to the minus 4. We are now 100-fold higher than when I first checked her. This is trouble. Here comes the monster. And by the way, just for good measure, we check MRD for NPM1. It's the same. Essentially, it's within pretty reasonable estimate. All right, so she's 2 years out, mild chronic graft versus host disease, rising level of MRD. Here we go. I'm going to give her the triplet. I'm going to make this thing go away. And so while ongoing gilteritinib, I folded in AZA and VEN. And oh dear, I got 2 separate admissions and a seizure for the aplasia that resulted from this. And in fact, you can kind of see how the counts go. I finally cried uncle and stopped the Gilt on day 40 to let her counts recover. But she had, so that's her absolute neutrophil count. It was just down for months. But nonetheless, she recovered, and then I could resume her gilteritinib. And so then now she's back on Gilt 27 months after the transplant. Morphologic remission, negative. So the triple erased it in theory. So now, and her NPM1 the same. So 36 months after transplant, she's on Gilt 120. She has pretty minimal chronic graft versus host disease symptoms, normal looking counts, feels well, and is going about her life. So here is just these are the FLT3 VAFs over time. So her transplant is here. And she's on Gilt during these times. And you can see the scale is rising there. I tried the quizartinib there. There's when I gave the AZA-VEN Gilt. So you can see. So this is how I'm managing this disease in my clinic. So AML is not one disease. You all now know this. It's a collection of diseases defined by mutations. There's an enormous interpatient intervariability in both the mutations and the targeted therapies that we use. Molecular analysis of AML is essentially how we operate this disease. You want to, unfortunately, you've got to repeat the analysis repeatedly. AML therapy today offers many more options. There are multiple trials underway or even completed demonstrating the benefit of the addition of single targeted agents to conventional therapy. But combining them is going to be the big challenge. And the challenge going forward is, what do we do when patients have multiple targets? Combine them, sequence them. What do you do with the overlapping toxicities? What about those drug interactions? So I will stop there and be happy to take questions.
Thank you, Professor Lewis, for that wonderful and a really illustrative talk, showing us what we have at hand now and how we can sequence. This session is now open for questions. Perhaps you could join us and answer yes. Thank you. Please go ahead. Yeah.
Thank you for the wonderful talk. I just wonder what would you do to this patient that has broken through or not getting MRD negative after 3 years of guilt and finally became negative? Are you going to keep her guilted for life?
I have no idea. What do you think I should do? The problem is I'm literally making this up as we go along. Where medicine, there is an art to this, I guess. I'm being arrogant, I guess, but I mean, and that's why I don't believe that there can be one recipe. You can't just say, this is recipe A and everybody over age 65 needs to get this. You have to use all we know about the disease, all we know about the mutations, the targets, PK, my morbidly obese patient or my patient with some weird genetic thing that I don't understand, and do the best you can. In her case, that was so difficult to eradicate. I don't want to stop it, right? And she doesn't want to stop it either. But she has mild chronic GVH. Am I going to get into trouble 3 years from now? Is she going to get skin cancers or mouth cancer or something? I don't know. And guilt only mildly augments the GVH, so I don't know how much that's going to do it. For now, she's absolutely staying. I haven't had a problem out of her since 1 year ago. So she's been peacefully on the drug for a year, and you know, she hasn't caused me any trouble, so I don't see a reason to stop. But the other one is more challenging, IDH1 guilt. What are you going to do with that one? So I can do MRD for NPM1, and then my plan, I think, would be to stop guilt first and then wait. I think the IVO is probably more important, but I don't know. And then follow MRD closely. I think it will give me time to react. I don't know. We'll see.
Yeah, and thanks, Mark, for your wonderful talk. Dr. Ho from Taiwan. Would you change your treatment choice if a patient has concurrent extramedullary involvement, such as leukemia?
I'm sorry, concurrent what?
Extramedullary involvement, such as leukemia cutis or CNS involvement, especially in use low intensity treatment as the front line?
So I have such patients, and I didn't give an example of that. I have a fairly nightmare. He's a grape farmer, young, and he had core binding factor with a FLT3 and relapsed after an allo with extramedullary disease, and both central nervous system and myeloid sarcomas. I hit him with the triple, and he relapsed when I stopped the guilt. He was on gilteritinib post-allo, and I stopped the gilteritinib, and he relapsed in his central nervous system quickly, which I've seen on more than one occasion. And so he says, why did you stop the gilteritinib? And in fact, he had sarcomas all over the place. The gilteritinib was clearly suppressing things. So I hit him with the triple, did a second transplant, and he's on guilt now. And it worked. He's a year and a half out from that. I don't know. And he's not going off the guilt. He would like fire me if I tried to stop the guilt. So there is another case, but the extramedullary disease in particular, guilt is very effective for. It gets into the central nervous system, I think, better than any of the FLT3 inhibitors. So I'm usually going to guilt as a guilt-based therapy for that kind of disease.
Yeah, thank you. And the second question is, how do you treat the secondary AML post-MPN transformation?
You mean with or without a FLT3? Or just in general? Oh, God. I usually look at the patient in despair and pray that there's an IDH mutation, which happens not uncommonly. So those are like my only long-term survivors had IDH mutations, and they actually have a durable response. You can give them aza-ven ivo or aza-ven enna, and you can often get durable responses. I have never found any reliable approach to if they don't have a targetable mutation. To be honest, make up whatever you want. You can give them azaven; it doesn't last very long.
Fantastic talk, Professor Mark.
There you go.
I have two questions. So, you at the presentation, the second patient. So, why that patient and you give them 8 milligram maintenance therapy, but at low burden MRD clone persisted for long term?
You mean why did I use 80 to start with, or?
Yeah. So the patient received the 80 milligram
Yeah.
gel.
I started at 80 on day 39.
Yeah. But so low MRD level persisted.
I didn't have one. Remember, I didn't know what her MRD level was. We didn't get it correctly sent post-transplant, and then she missed her follow-up appointment. So I was in the dark on her MRD. And just, I wanted to get her. My usual approach with guilt post-transplant is start at 80 and bump to 120 if they aren't complaining.
That MRD clone had some resistant mechanism for the
Yes, but the only way I would find out the resistance is if I let her relapse, right? So I'm not going to do that. I mean, I suspect there's a RAS mutation.
Okay.
But a similar case I had multi-clones. There were 3 clones, and I could not stop it. I couldn't stop it with the triple. I couldn't stop it with quiz. I couldn't stop it with guilt. High guilt, I gave 300 milligrams of pozo, 120 of guilt. I increased her to 200 guilt, and the clone still rose, and she died. That's the case. Those multi-clonal disease, there were 3 different clones down there. That's a different biology.
Okay.
I was wondering if we did not see a RAS mutation emerge. That's usually the way things get resistant. I don't know with this case I presented what her mechanism of resistance was. I don't have an MRD for all the different resistance mutations. I mean, it could have been a RAS. I don't know. I made it go away with azaven, and now hopefully I won't see it again. I don't know.
And the second question is regarding the NPM1 and KMT2A positive AML patient. So, please let us know your opinion, recommendation of the maintenance therapy using the menin inhibitor.
I don't know yet. There are clearly responses with that class of agent. The problem is NPM1s are better behaved disease, aren't they? So, you know, here the menin inhibitors are going to be particularly tricky to work out how we combine them, because Zifto, Blexi, and Rev are all pretty fat soluble CYP3A4 metabolized. They're going to interact with guilt in a big way. So combining them, if they're NPM1 FLT3, what do you do? They seem to combine very well, all of them, with Ven. Not a big deal. So I suspect we're going to want to use azaven menin up front in anybody with an NPM1 and ignore the FLT3 part. And then if they have a FLT3, fold your FLT3 inhibitor in later. Because the whole biology of a FLT3-driven disease is it will go into remission and then it's going to relapse. Okay, so just get the patient in remission and pop the FLT3 inhibitor on afterwards. Problem is, doing a trial like that, the drug companies don't want to do that because they want their drug given from day one forever and the other drug add later, you know. But we're going to have to get around that problem because we've got to figure out how to sequence these things.
Thank you. Thank you so much.
I think the other question, Mark, can I ask you, post-transplant, do you still think, especially with these targets, there's a role of donor lymphocyte infusions? Do you ever combine introducing a novel therapy with DLIs post-transplant? Yeah.
Stay for the next session and I'll show you a case.
Okay, fine. We'll wait for
Hi, I'm Chen Tang from Singapore General Hospital. Yeah, so I'm just wondering about the context of sequence of mutation. Say you have a DNMT3A, NPM1, and FLT3. And NPM1 mutations always starts off with DNMT3A, TET2, or IDH kind of mutation. So, and in the past, when we give chemotherapy, they go away. We don't see clonal hematopoiesis as a problem. So the question is, you know, are these things leukemia generating clones, or are they just, there in the context of NPM1 without which?
I don't think you're going to find a one rule. You know, patients are going to have some one and others the other, because I'll give chemo to some patients with a nice TET2, and I never get rid of that TET2 even going to transplant. They're going to do transplant with chip. Whereas other cases, you make the whole thing melt away. So I'm afraid AML is not going to cooperate in your classifying it into one or the other, I suspect.
Yeah, so then the thing is, let's say if they're in remission, if you still see that DNMT3A clone, are you still going to be worried about?
Yes. Well, we know that,
or they are
persistence of chip is a bad sign. Yeah. Oh, yeah.
Thank you. Did you have a question?
I'm not sure whether this is out of scope, but I want to know what's your approach to TP53 mutated AML.
Despair.
Yeah, I recently
actually, though, no, we're making a little bit of progress. So we have shifted to decitabine. And remember those strange report that came out of Tim Lay's lab that said we gave thunderous amounts of decitabine and everybody went into remission and nobody believed them. And furthermore, remission was basically an ablated marrow. And so we all mocked them. But during the pandemic, when we couldn't treat some of these patients, we started telling clinicians out in the community, just give weekly low dose. There's this crazy guy named Yogan Santara Raja who says metronomic or tiny amounts of decitabine will work. And we would get the reports back, oh my God, it worked. So we shifted to giving decitabine based for all of our TP53 complex. And our survival has jumped up. Now, I'm not saying it's great, but we actually are getting a few patients to transplant. We do not give venetoclax except under sort of salvage. So we start our patients now. So my current approach, I'm not claiming this is the thing everybody should do, but this is what I'm doing. You get 5 days of IV decitabine to start your induction. Naturally, we have it's the US. If we can spend some money, we'll try to spend more. And so we've found a drug Incovi, which is a wonderful pill that you can give that basically does the same thing. And so we're doing decitabine or Incovi for these patients and getting a lot of them into remission.
I know Mark has done an excellent job, but in interest of time, can we have the panel on board so that you can save time?
Oh, you guys didn't invite the panel.
We need to get the panel and work, and then we will keep the time because we have other people watching us simulcast. So maybe panelists go on board quickly, do our work.
Thanks for the reminder, Professor Gao.
Yes.
I'll invite all the panelists on. So can I have Professor Hao An from the NTUA Hospital, Taiwan, Taipei, and Dr. Anskar Lewin from the Hong Kong University and Queen's Mary Hospital, Hong Kong, and Dr. Yvonne Low, who's from Curie Oncology at Singapore. Please join us. Thank you.
Dr. from Taiwan. Thank you very much for your wonderful talk. You show a very beautiful case using the MRT to guide the treatment. So my question is, sometimes the relapse acute leukemia, the kinetics, not very easy to predict. So my question is, if you change the treatment based on your MRD, when will you recheck the bone marrow?
So the problem is you have to be able to do it. And I like bone marrow. I like first pull bone marrow.
Yeah.
Okay, so with the FLT3 ITD, the kinetics are enough that it gives you plenty of time. I showed you over the course of years, it doesn't rise that fast. Whereas we have other kinetics like core binding factor 821s, they go up fast.
Yeah.
And version 16 gives you time. So we're going to have to learn which mutations are fast and which ones are slow. And it's not going to be a consistent finding. I hate to break the news to you.
So you based on some the genetic to decide when.
Yeah, I get nervous, and that's why I think cell-free DNA from blood is going to change the field. I'll bet it really does, but that's a few years away.
Okay, thank you.
Good afternoon, Prof. Levis. Is there a VAF threshold that you may not consider the IDH inhibitors? I recently have a patient that is very refractory, but the IDH, I think it's IDH 1 or 2 mutation. It's only about 5 to 6%. I wonder I even want to keep it.
But IDH mutations, the way they work is they generate 2-hydroxyglutarate, right? They spew out this oncometabolite that can diffuse out of the cell and transform its neighbor. So you don't need, in other words, basically you can turn your cell into a zombie by spewing out this chemical. That's thought to be one reason how IDH mutations at low VAF still respond to an IDH inhibitor. So I would be absolutely trying an IDH inhibitor there.
So second question is just like your case number one. If you have a few actionable target, so after you target the first one, before you change the change to the other targets, do you repeat the NGS to see the threshold and help you to?
So I didn't have an NGS. I did not have an MRD assay for that FLT3 mutation. Is the problem? I don't. That was a D835Y. I don't have a sensitive assay for that. I only have the NPM1 assay. And I certainly could have done that. You're right. I could have just given the IDH. That patient may have been in remission just on the ivosidenib, without doubt. But the data would suggest not, that a high VAF FLT3 is going to cause trouble. And so I was in so much of a panic with her. I just she couldn't take much therapy, so I slapped both drugs on. You're right. I may not have needed the gilteritinib. We can do this better. I totally agree, but I'm pretty much making stuff up, as we go along.
Ashley, yeah.
Can I just ask? So Mark, if you put the two drugs together, ivosidenib and gilt, do you find more cytopenias than if you use gilt alone?
I've done it in about 6 patients, and no, it's quite remarkable. But I think the IVO causes gilt to go down, not up. IVO actually induces CYP3A4 and makes levels go down. I've never seen any cytopenias with the combo. It's very well tolerated.
Thanks, Mark. Following from Yvonne's question, for your N=1 case 2, for FLT3 persistent MRD, is that going to be influencing your thoughts and practice with triple therapy earlier versus persistent maintenance?
Triple therapy early? You mean giving aza-ven gilt in a newly diagnosed patient?
Well, in your patient who had persistent FLT3,
yeah,
and rather than maintaining on gilt,
yeah,
would you think about using that triple combination earlier?
Well, I transplanted her, which was my idea of just, I'm going to solve the problem with the Gordian knot here. But in a patient who's not transplantable, oh no, I'll probably pull out something more vicious because the patient was in full remission at that point,
yeah,
and would tolerate a triple, I think, barely. So yes, obviously I would pull it out earlier.
Thanks.
Hi, Mark. A couple of questions I want to, based on your presentation, because one of the pathogenesis model that you put out about FLT3 and GVHD and also dendritic cells, right? So therefore, based on the theory, is it possible that FLT3 inhibitors would also work in FLT3 wild type in the context of post-BMT kind of maintenance?
So that was brought up very early on with the BMT CTN and the Morpho trial. Oh, we want to do this in wild type. I don't think it's enough. I mean, I think it augments a little bit of FLT3 of GVH, and it can be a real pain sometimes to manage. But I kind of doubt it's enough to add a therapeutic benefit. But I can't say in the absence of a trial. That trial was brought up as a viable.
So the quantum wild.
Well, quantum wild is not going to do that because those patients in general aren't being transplanted, only in the post-transplant setting. So you're not going to be able to tell, and I can guarantee you quiz will cause some GVH problems.
Definitely, yes, definitely. Well, the other question I have is because now I do understand that if FLT3, based on NGS FLT3, if it's positive, then, you really have to ring a bell and make sure that, monsters was there. But in the context of a negative NGS FLT3, so because there are situations like, FLT3 could be a subclone of whatever major clone. So how would you take that,
So it depends on the original presentation. We're looking at, for example, the triple. If you see a DNMT3A, NPM1, you had better look for a FLT3 because if it's not there now, it will be. Whereas if you see an SRSF2 and a TET2 and a FLT3 clone at 4%, that FLT3 clone is I often just ignore it. It's not going to be part of the, so you're going to have to take it in the context of the co-mutation.
That makes perfect sense. And the very beginning that you mentioned about, the various treatment paradigm of, as we all know that Ven-Aza perhaps is for unfit and elderly people, right? But there are also emerging data to show that even in fit and otherwise, patients, at least as far as the induction efficacy is concerned, it seems to be comparable, if not even better, for certain subtypes of AML. So what's your take on it? Like how
I
far
think it probably would be better. I think a 30-year-old coming in with FLT3 ITD AML could easily do just as well. Because the data we have on older patients with FLT3, we're doing just fine with them. And they're getting Aza-Ven. In fact, we're presenting a series of these triple mutated patients. Most of them got Aza-Ven and they're long-term survivors. So yes, I think your point is well taken. Aza 7 and 3 might finally be going away someday.
That's all we are looking forward to.
I think there is a plenary in ASH that is
my former fellow. I'll thank you very much, Amir Fatih. Yes,
it's going to be a lot of discussion there in the plenary.
But FLT3 was not allowed to be included.
They did not allow them.
Neither
But
was
I guess,
Dagger.
yeah.
Oh, but I think it absolutely applies.
As the trial is called Paradigm, I think it will start a paradigm that people will start pushing into other diseases.
But for example, also at ASH, and I think this is in my own practice, Aza-Ven is lousy for TP53. You will just kill these patients. So subtypes, there's not one disease.
Yeah. So now that you've raised the question of P53, can I ask you, we also have found that INCOBI works for the patients that we can get access to. We've got limited access of INCOBI, but it works. What do you do post-transplant? Do you get it back in again?
So I don't know yet. There is this interesting randomized trial out of China showing patients randomized to no therapy versus low dose decitabine with GCSF. It was a decent study, looked kind of believable. And so I just got a patient to the other side and she's collapsing with GBH. I haven't been able to start this thing, but I'm trying to. There's so few patients that make it to and through transplant with that disease. I mean, you lose 95% of them before they ever get to transplant. Maybe we'll do better I'm doing better with the decitabine approaches. I'm getting more to transplant.
You have a patient now who has got a FLT3 TKD and a KMT2A. Which inhibitor would you favor?
I would probably go, both. We actually have a protocol where we could put them on enzomenib and gilt. So there, and I can do both. Being a U.S. profligate spendthrift, I can put them on revumenib and gilt if I wanted to. I'm afraid so. If I had to pick one, I would probably go with the KMT2A.
Do you think maybe one followed by the other?
Well, then I get into pharmacokinetics. Enzomenib is water soluble and pairs with all of them. So if I could use enzomenib, I would have no problem doing it with any of them. But if I'm doing Zifto or Rev, and I'm sorry to the poor J&G, I've never used Blexi, but if I'm using those, then that's going to get a little tricky with dose reduction because the menin inhibitors do cause some myelosuppression. And that the instant you add gilt to anything, you get myelosuppression. So, but I would think that the KMT2A is more important to target.
About the TP53 and FLT3, that seems to be two kind of important diseases. I do concur with what Mark has mentioned about the difficulty of getting people with TP53, MDS, AML into transplantation. But I just want to have your thoughts on and comment on, like, for those who successfully bridge to transplantation, TP53 and perhaps FLT3, two types. It seems to me, my personal experience is that those of the FLT3 are more susceptible to a GBL effect. Because, like, with bridge to transplantation, they should be fine, maybe with FLT3 inhibitors, maybe with the other maintenance strategy. Whereas for TP53, even though if you can successfully bridge to a transplantation, most of them will relapse no matter what you do. So on a theoretical basis, does it mean that the GBL, for some reason, doesn't really work so well for the TP53 mutant types?
So you would want to you're talking about giving sorafenib post-allo to a TP53 patient or a FLT3 inhibitor, any FLT3 inhibitor.
I just wonder whether there's anything that we can do, because I have tried.
No, it's
things,
hopeless, Ansgar.
Yes.
No, I don't know. Obviously, yes, we're interested in immunotherapy. Maybe that's why the only known cure is a T cell, apparently. Right. And this one lady who I can't start GCSF decitabine on has so much GBH that maybe that's gonna fix her. I don't know. She hasn't relapsed.
Right.
And the one person I know who's managed to cure one of these people said that's how it worked. It was just so much GVH that actually, you know, so I don't know the answer on SCAR.
It's always difficult.
Regarding the TP53, I think the recent immune profile suggests the TP53 mutation belongs to immune cold phenotype. So it could be not easy to control by current target therapy. But some data suggests the interferon could induce the immune profile change and to induce more GBL effect in TP53 mutated patient. So what's your comment?
You want to give 7 and 3 or azaven and interferon, do you? Or
post-transplant.
Post-transplant interferon. Post-transplant interferon. I understand why. I understand why you want to do it. Well,
Yeah.
go for it. Write a trial and go for it. I mean, interferon, you and I have given interferon. Patients don't like it. But you could give pegylated interferon. They tolerate that. And a patient who has not had much GVH, you could certainly get away with that. I don't see why it's, you know, go for it.
Some of our colleagues from Queensland have actually done a lot of work on them. They have used interferon and subsequently peg interferon post-transplant, mostly in early relapses situation, but they have managed to show that you can induce a graft versus.
Well, I mean, it certainly would be, if you could, the problem is, I guess go find an industry that makes a patented interferon to pay for the trial, because you need a trial to show that, right? So.
About interferon, because we did a study on decitabine, in fact, like, you know, and serially monitor this patient in terms of single cell transcriptomics. And we did actually demonstrated that those who responded to decitabine transiently, though, that they have a surge of interferon. So therefore, it could well be, you know, one of the kind of, not the entire, obviously, but one of the mechanisms whereby they could have get a bit of a transient effect by the immune kind of eradication, but it's not eradication, but suppression, put it this way.
Surprised me. It's a reasonable idea for a study.
Nobody's going to fund it easily, right?
There is that.
I think because in Asia-Pacific area, drug accessibility and affordability is the most important issue to tailor personalized treatment. For therapy-related AML, the MD Anderson suggests the cladribine in combination with main-based treatment alternative with low-dose RRC and venetoclax. What's your comment? Cladribine in combination of a low-intensity treatment.
So MD Anderson announces the cure of AML approximately every other month.
Mark, is the Cody.
I know. MD Anderson, they're aware of that. They occasionally invite me to their meetings and we have a fight. It's great fun. They love a good argument. Cladribine was studied, as you know, originally. In fact, we have a Polish faculty member who bristles at MD Anderson claiming credit for cladribine, because the Polish cooperative group first studied cladribine and says this works really well. We've been using cladribine-based therapies for years. This particular combination, no, we don't tend to use it up front. It has not supplanted azaven for us. But, you know, until I see a randomized trial, which I will point out MD Anderson specifically and programmatically does not believe in, then I'm going to just say, whatever, dudes.
Okay, this is a follow-up question. So you mentioned about the frontline, so many drugs in your slide, the busy slide. So also Dr. Ho mentioned the nucleoside combined regimen. So could you mention about the possibility of chemo-free, as you mentioned in the morning session, chemo-free and transplant-free setting could be possible in AML on your mind in the near future or?
Well, we already do that with APL, right? That's chemo-free. Mm-hmm. That's easy. Chemo-free. So yes. I mean, I could well imagine venetoclax and a menin inhibitor and a FLT3 inhibitor let's toss them all together and stir. I mean, I don't mind, you know, one objection I have to triplets is they're being used in the older, frail population, which is not the population that can handle it. You've already brought up the fact that aza-ven is probably going to supplant 7 and 3 even for younger patients. We're going to get bolder, and the younger patients can tolerate long aplasias. So yes, I would think we're going to start to be able to do things like that. Absolutely.
What about transplant, Mark?
Just transplant them. Or you mean, or make it go away? Which?
I guess just bringing in spotlight what Dr. Kim said, that we spoke of novel therapies, we spoke of MRD techniques in the AML session, and we said,
that is happening. I'm already in a wonderful feud with. I feud with lots of people. I have fights with them. The BMT-CTN, which is a cooperative group that we did the Morpho study with, they're very unhappy with me because the data that we're presenting at ASH and I'm publishing, and which aligns tightly with data out of the Quantum First study with MRD, is if you're MRD negative after 3 or 4 cycles of intensive therapy, your survival is 90%. Okay, beat that with transplant. And so they're gnashing their teeth at me and saying, no, you can't take the chance. They'll relapse in the middle of treatment. They won't relapse. Nobody relapses in the middle of FLT3 inhibitor treatment these days. That's old. That's happened in the past. So the data out of Morpho is we have all these patients that couldn't go to, the reason Morpho was negative is Ural's fault, by the way. In Asia, no FLT3 inhibitors were approved during the Morpho enrollment. And it wasn't your fault. You didn't have them regulatory approved, a lot in Europe as well. And it does take longer to get patients to transplant. So we have that data. And so if you keep giving 7 and 3 and HiDAC to a FLT3 ITD patient, 3-4 cycles, what are they going to do? They're going to relapse. We know this. And they're not eligible for Morpho. So those patients here didn't go on Morpho. The ones that eventually did 7-8 months after diagnosis didn't need a FLT3 inhibitor. And the other argument is they didn't necessarily need transplant. And we can clearly see using the MRD, patients who did get FLT3 inhibitors with chemo, the MRD levels go right on down to 0 after 4 cycles. And so those patients don't need, if they go to transplant, they certainly don't need the drug post-transplant. And what I'm raising is they didn't need transplant, you guys. And that aligns with the data out of Quantum First. So, oh yeah, I think we can avoid transplant in a large fraction of FLT3 patients. And this is opposite what I said 10 years ago. Transplant all of them because we didn't have MRD and we didn't have good FLT3 inhibitors. Now we have both. We can identify. So then the next question is the patients on Quantum First were on a FLT3 inhibitor for 3 years. Okay, do they need it for 3 years? But you absolutely can avoid transplant in a large fraction of these patients using MRD, using what we know about the disease, using these targeted agents. No question. So they're, the cooperative group, the transplant cooperative group is unhappy with me about this.
Okay, then I will give you some core questions. I think you may be knowing about that point. One of your colleagues in Hopkins was very interested in the kind of microtransplantation. Am I right?
Microtransplantation. No, we have only like one recipe we use. We're very...
or Dr. Jiangxin Wang. I think this platform, microtransplantation from China, actually published in the GC or something. So I think because this mention is about the possibility of transplant free, so on the way. So would you comment on?
You mean the macro transplant?
Some specific.
Right.
Yeah.
So that experience from Beijing is a small, is a one hospital, but not widely used in China. So in fact, the hematopoietic cells after drawn from blood, we will do the manipulation. So this is a scale. It's also the secret scale. Other people can't repeat it quite well. Although they say they claim very good result in that hospital, but we don't have never get that kind of experience for my own. So I don't know.
Difficult to reproduce. Are you sure it's not out of MD Anderson?
No. No. This claim is quite good. Yes. No.
Okay. But I think it's a novel. The T cell is what you want in transplant, right? So the concept.
Already they claim they have the minor the chimerism, so they can identify T cells from donors. They say.
But I mean, that's what you want in the process. Is you want the T cell, you don't want the chemotherapy. So the concept is perfectly sound.
Yeah, it's also very safe.
Yeah.
Okay, then my last question about you mentioned the switch from gilteritinib to quizartinib. So actually, the Astra is very sensitive to that point. So would you comment? What's on your mind, frankly?
Well, so I worked with both. And by the way, did you know Astellas used to own quizartinib? A lot of you guys didn't know that. So I have worked with both drugs very tightly. I'm quite familiar with both. Quizartinib is better against wild type, without doubt. That's why they're doing it in quantum wild, and it will cause more graft versus host disease. I was hoping that it would have some effect on these monsters, as I call them, rising from the deep, but it did not. And I've done it on more than one occasion. And so that's all I can comment. I mean, gilteritinib is a very good FLT3 inhibitor. It's all you pretty much need to inhibit the target. Quiz is going to do something different in the wild type setting, I think, but I don't think it offers much of an advantage against an ITD.
So just extrapolating on that, can I ask you a question? In the perfect world, you had access to every FLT inhibitor. How would you?
I already do. So
you live in a
and the world is far from perfect. Just go back to where I'm from.
In a perfect world. So let's say we were all in a perfect world. Yes. What sort of paradigm would you use? How would we decide about which FLT3 inhibitor are we going to combine our treatments with?
I would prefer GILT. I've used both. I do prefer GILT. There's less this kind of annoying QT thing, which I think is stupid anyway. That I don't care about QT prolongation, but all the junior people seem to. So that's a bit of an annoyance with Quiz. Quiz is a little more myelosuppressive, but they're both very good drugs. And so I actually had a pharmacist object when I wanted to move somebody from Quiz to GILT. And I said, fine, leave them on Quiz. They're fine. Quiz is a very good drug. So I think you've got two very good drugs. Obviously, it doesn't hit point mutations. But on the other hand, its activity against wild type may offer an additional advantage. So I'm not sure what's better. All things considered, if I had to choose one, I would choose GILT. But I would be very upset. I was making this argument to the FDA years ago, and they were being annoying, well, you already have GILT. And I say, I want both, thank you. I think they do offer complementary things. So I don't think I could choose. I want them both. I want GILT and Quiz. I don't much care for midostaurin. I hardly ever use that now.
I also ask you, we've been focusing on using novel treatments, transplants, but to make a decision on novel treatments, we need the information to decide on novel treatments. In your practice, how?
Cool.
Okay. We still in time. In your practice, how quickly do you get that information? Because we are now moving into a field where we are looking at starting everything novel. And I guess with FLT3 inhibitors, we had a bit of leverage. Day 8, you have 3-4 days to get your information. IDH inhibitors are starting on day 1 of treatment, whether you're going to combine it with chemotherapy or not. Should we start investing a lot in getting these results, and how quick is quick enough for us to start treatment?
Yeah, so I know the data on, it's perfectly safe to wait until you get your molecular data back. And anybody who's managed AML knows that's like a lie many times. It's like, no way you can hold off therapy while this patient's in leukostasis or whatever. So I think prioritizing getting the molecular, we're all checking our phones, making sure she knows. There's no way, we should be prioritizing getting the molecular data quickly because without doubt, technically it's difficult to do, right? I mean, we've got to come up with something better than NGS then. NGS has you've got sample prep. It actually literally does take some time. And then you have the bioinformatics and analysis. I mean, it's not, PCR you can do fast. I could do that in a few hours, but not NGS. So we need some form of different, and I think the technology exists. I think NGS kind of took over, Illumina took over the world, but maybe that wasn't the best platform really.
So Mark, do you think the TP53 expression by IHC is a good marker extender of NGS testing? Because TP53 do not have any hotspot. You need NGS testing. So some experts suggest that you can use the IHC immunohistochemistry to study.
But that only picks out when you've lost it, right? I mean, if you have a point mutation, you don't pick that up with IHC. So he's asking, I mean, there's an immunohistochemistry test. We have it. It's a rapid turnaround. It can tell you, but most commonly it lights up positive when the patient has a complex karyotype and a 17p deletion, right? That's when it comes up positive. What I've done more practically is I'll call our karyotype lab. Karyotyping is an ancient technique, right? Ancient, it's older, like our age. You can do it in 48 hours. And so most cytogenetics labs aren't given information on the patient. They just take them as they come in, and we send all these mindless bone marrow biopsies from patients in remission where we don't need the karyotype. New Lukes, I ask for an immediate karyotype, and they can get that quicker than NGS. And if they have a complex karyotype, we find out the karyotype within 72 hours. And if they've got a complex, halt, do not touch this patient with anything other than decitabine. And we'll often then wait until the NGS comes back. So our algorithm actually has changed. We went back to karyotype to getting that fast because I need to know if the patient's a TP53, a real one. And I don't care if they have a TP53 without a complex karyotype. I can manage that disease. It's the complex karyotype.
I concur completely, particularly when it is 17p deletion, for example, or monosomy 7, monosomy 5. Those are the really at risk.
Yeah.
Complex karyotype, then almost like maybe 70, 80% of these patients will have TP53.
Yeah, so we screen if we will negotiate with our karyotype lab. What can I get first? Can you give me an MDS fish or can you give me the full karyotype? Whichever you can get me quicker is going to be an adequate screen because our MDS fish will pick up those patients as well.
Well, thank you. We've had a wonderful session. We are just in time. Remains to me to thank Mark and all the panelists here. We've had a wonderful decision and a wonderful audience that has been very interactive. So thank you all for attending this session. Thank you. I close the session.
Switch. Change seats. Recording in progress.
Ladies and gentlemen, may I invite you to take your seats. The MRD Forum, Redefining Relapsed and Refractory Disease in AML, will begin shortly. This forum is a collaborative initiative between APLC and Astellas Pharma. Please note some presentations may include investigational or unapproved uses of therapies. This content is for medical education only and should not be considered promotional. This meeting is hybrid, so we will be live streaming across multiple countries and it's being recorded. We will be using Slido for Q&A. Next. And you'll find your QR codes on the screen for participation. Professor Mark Levis will begin the session shortly, but it seems like he's taking a quick bio break. Oh, here he is. Dr. Levis, could we invite you to the stage? So now we'll invite Dr. Levis to the podium to start the session.
Okay. Good afternoon. Welcome to the MRD Forum. As you know, I'm Mark Levis. Today we are going to discuss how MRD testing and molecular diagnostics are completely reshaping the way we manage AML and how we define relapsed and refractory AML. So the learning objectives today, we're going to review standardization, which is a big deal in MRD, and to discuss how evolving MRD practices can shift the diagnostic landscape. In other words, patients in remission, but maybe in fact they're relapsing, like the cases I was showing you here. I know the relapse is coming. So we have expert faculty across multiple countries, including virtual satellites in Singapore, Russia, Saudi Arabia, United Arab Emirates, and over in Kuala Lumpur, which is also hosting hematologists from Vietnam. And I think all right, well, so before we begin, actually we have 4 different satellites: Singapore, Russia, Vietnam, Malaysia, and Saudi Arabia, UAE, with each one with different chairpersons. And they're now joining us. Okay, and I'm joined by my distinguished faculty, whom you all know, Kim Hee Ji, Zhenjing Wang, Ansgar Long, and Ashish Bajel. And virtually, we have Jad Othman from Royal North Shore Hospital. All right, so now before we begin, I want everybody to complete this short 3-question pre-meeting quiz. And what you want to do is use this QR code, scan it, and that will, this is called the Slido QR code. And this is going to help us understand whether we actually end up teaching you anything today and have met our learning objectives. So while everybody participates in the quiz, everybody starts scanning. We'll give you a minute. Who's saying that? Oh, go. All right, so we can go ahead and get started. It's my pleasure to introduce our first speaker, Dr. Ashish Bajel from Peter MacCallum Cancer Center and Royal Melbourne Hospital, who's going to provide an overview of MRD guidelines from a clinical perspective in AML.
Thanks, Mark, and thank you to Professor Go and Estella for inviting me. My job is to speak about the overview of MRD from a clinical perspective. Those are my disclosures, and that's the overview of the talk. I'll be touching basically on the NCCN and the ELN guidelines, and speaking on the classification and the timing, and also speaking on what trials are telling us and what are the practical applications that we can do with MRD. So MRD, we are all aware of, measurable residual disease, and we very well know that when patients are in morphological CR, we can still detect leukemic cells. It just depends on what kind of technique or platform that we are going to use to detect those. The more sensitive the platform like NGS, we can detect it, MRD at a depth of 10⁻⁶. With the less sensitive platforms like FISH or cytogenetics, it's much at 10⁻². But MRD is influenced by a lot of variables, and it's starting with the treatment, whether we are going to treat patients intensively or with non-intensive treatment. What's the target that we are actually measuring? What is the platform or the testing method we are using? What's the sensitivity of that? When are we testing for MRD? At what point in the treatment? Is it post-induction, post-consolidation, pre-transplant? And lastly, what sample are we using? Are we going to use peripheral, or we complaining again? Or we're going to use bone marrow. So these are the variables that we have to think about when we are actually testing for MRD. Now there are established techniques for MRD, and the two most established techniques are flow cytometry, which we can test MRD either by using a leukemia-associated phenotype or difference for normal, applicable to broadly 80 to 90% of our cases, and the sensitivity can range from 10⁻³ to -4. The other established technique, as Mark previously said, is the qPCR, which has definite targets that can be measured. Could be the NPM1, the core binding factor leukemias, and probably a bit more less validated, but emerging targets like KMT2A rearrangements, which can also be measured, and the NUP214. But emerging around our other platforms like NGS, which is increasingly becoming popular, is very sensitive. And it, in fact, in the ELN guidelines just finds the role of exploratory, but the NCCN guidelines, which are more updated based on Mark and his colleagues' work, now has recommended that FLT3 ITD MRD should be measured on NGS to test for MRD. And of course, the last platform is the ddPCR, where we are hoping that will give us more sensitive results and the more sensitive technique. Now, why are we interested in MRD? Because we know it impacts the overall survival. And this Kaplan-Meier curve on the left is a meta-analysis that looked across a range of clinical trials of patients getting chemotherapy, range of timings of MRD, post-induction, post-consolidation, and range across testing platforms. And the outcome was that irrespective of the testing platform, the timing of MRD, if you were MRD positive, you had an inferior survival. What about pre-transplant? And this is work on the right from my colleague Sun Lu, who looked at some work which was collaborative work between Australia, UK, and Taiwan. And we looked at patients who went into transplant for FLT3 ITD. And it was shown here, as the graph shows, that if you are positive, irrespective of the depth of the MRD, your outcome post-transplant is going to be inferior, irrespective of whether you have a myeloablative transplant or a reduced intensity transplant. So it does impact survival, and it's quite important. So what do we use MRD? We want to use MRD to establish whether we've got a deeper remission status, or we want to assess the relapse risk in our patients. We want to identify impending relapse, which Mark has shown from his cases. And we are hoping that it will be a surrogate endpoint for drug approvals in the future. Now, getting to the ELN, which is the criteria, the ELN defines MRD thresholds for various testing techniques. For flow cytometry, it defines a threshold of 0.1%. Anything more than that is positive on flow cytometry. For qPCR, it defines the number of the threshold cycles and the replicates that should be positive. It also defines an interesting entity that is called as MRD low level, and that's originally described only for NPM1 and core binding factor leukemia. But the reason I've highlighted that is to bring to note that the threshold that is acceptable based on MRD low level sensitivity, which was initially floated as an innocuous scenario, is actually 2%, which in other testing platforms would be considered a significant level of MRD and perhaps needs to be having a look at. As regards to NGS, this is still a work under progress. What's the actual threshold of NGS? But the ELN 2 or 2021 guidelines set a threshold of 0.1% as a positive MRD. And we can use these definitions of MRD, then define the response of our patients, whether they are in a complete remission with MRD positivity or they are in a complete remission with MRD negativity. And of course, they retain the category of MRD with low level MRD persistence. And as I mentioned, that there are some concerns about this 2% threshold that they said. The ELN 2021 defined MRD relapse as a single log, at least a log increase on 2 successive samples that was measured for MRD. That was a definition, and hence we need to repeat the testing for MRD to be sure that our patients are relapsing. Of course, this is also again coming under the scanner because it depends on the target that you are measuring for. And for some mutations like FLT3, ITD, and KPMT2A rearrangements, just duplicate testing may be too slow, and a patient might have had a morphological relapse by then. The timing of MRD, the ELN again defines the timing of MRD, saying not only we establish our markers at diagnosis, but we do it after 2 cycles of intensive chemotherapy at the end of treatment, and then follow up our patients either on bone marrow or peripheral blood, either 3 or 4 monthly or every 4 to 6 weeks, at least for a period of 2 years. And they define it upon the target, the NPM1, the core binding factor leukemia, or irrespective of these targets as well. We cannot forget APL, and as we discussed, this is a well-established scenario where arsenic ATRA have changed the paradigm. And again, the ELN tells us criteria. The ELN for the low risk says that once we've achieved MRD negativity, we don't need to monitor, but for the high risk, we keep monitoring for a period of 2 years. What about the less intense treatment? This is where some work has been done with the ELN David to look at non-intensive treatments like Ven-Aza. They've retained the same technical guidelines on our patients, but based on work that was published by Jad Othman, showing that NPM1 MRD, at least after 4 cycles of Ven-Aza, is of prognostic significance. That has been the timing that's been chosen for non-intensive therapies. There are a few elements here in MRD that are unanswered. Should we always look at MRD relapse versus MRD persistence? What about targets like FLT3, ITD, or KMT2A rearrange? Is any level of positivity significant in this? And these are some of the questions that we are hoping that the next iteration of the ELN guidelines are likely to address. I'm told that they are already ready and submitted, so hopefully early next year we should be seeing these guidelines. The other one that I already put under the scanner is the role of MRD low-level persistence, which 2% is quite a high threshold to consider to let it just remain unattended. Now, when we talk of MRD, we've always said that we need to repeat the testing, we need to confirm the MRD positive. But how do we tackle MRD positive? Does it have to be clinically actionable? And there are different strategies that people have thought about targeting MRD. One, of course, is consider an allogeneic stem cell transplant. However, we want our patients to be in the deepest response before they go into allogeneic stem cell transplant. Mark's work in the Morpho study has shown that perhaps post-transplant strategies can help us overcome the problem of MRD positivity pre-transplant. But what about clinical trials using novel agents to address this issue? And I'm going to give 2 examples of clinical trials which have been looking at this. And the first example is work done by my colleague Ying Su and Andrew Wei from Australia. We participated in the study, which is the VALDAC study, and used the concept of using venetoclax with low-dose RSC in patients who are either MRD positive or had oligoblastic relapse. And you can see that with subsequent cycles of venetoclax LDAC, you get a MRD negativity situation, and that MRD negativity translates into a better survival of our patient. The next example that I want to put forth is this visionary trial that Andrew Wei is leading in Australia and in MD Anderson, and it's the AML M26 intercept study. Essentially is evaluating the use of novel therapies for preempting early relapse or MRD relapse, and has different phases. The first phase is identifying or harmonizing the MRD testing across various centers so that we are talking and looking at the same results to decide on MRD positivity. Then looking at central confirmation of MRD, and there are 3 elements here: patients with MRD relapse where there's a log increase, patients with MRD persistent, for example, KMT2A and FLT3, we are looking at MRD persistent, or patients with oligoblastic relapse. And then based on the target, looking and selecting novel agents that can be used to treat these MRD relapse patients to see whether we can translate it into a better survival. So this work is still being done and was presented last year at ASH regarding the revumenib. So putting it all together, what are the practical applications of what I showed? We have a ELN guidelines to tell us about MRD, but how we translate these guidelines is quite important. So it's important to look at our workflow so that we get results in a timely way. We follow those results and we can action those results. And it's important that we have some regional adaptation of these MRD guidelines. Australia, the ALLG has done it by adapting the MRD guidelines so that we know where the samples are going when the testing is coming. And of course, we have some unknown questions that we hope that trials will answer. Can treating MRD actually result in a cure of the patients? And of course, the important question is how long are we going to treat these patients? But this is a challenging area because we have rapidly changing field with newer targets. We've got better testing platforms and we have got more and more evidence that we have to deal with. That's my last slide, and I just feel that's just to acknowledge my colleagues who work with me. It has always to be a teamwork regarding MRD. So we've got a molecular labs, we've got a clinical departments, and also the stem cell transplant colleagues too. Thank you.
Okay, for our next segment, we're going to cover molecular MRD approaches. Dr. Ansgar Lung will speak first, and then he's going to be followed by Dr. Jad Othman, who's going to join us virtually from the Royal North Shore Hospital, University of Sydney. So, Ansgar.
Good afternoon, everyone. First of all, I would like to thank the organizer for inviting me to talk in this particular meeting. And I'm going to talk about a very specific scenario of MRD detection on day 30 post-transplantation and how much it can help in terms of treatment or management or prognostication of patients with acute myeloid leukemia. Here's my disclosures. And thanks to Ashif, in fact, saved a lot of my work in terms of presenting. Suffice to say that now, in general, we are talking about 10 to the power 12 of leukemic cells when we have a diagnosis of acute myeloid leukemia. And after treatment, and the pathologist congratulate you on getting a remission. In fact, you still have 10 to the power 9 of leukemic cells in the body. And to the bottom of it, when you said even you get the MRD negativity, in general, it is believed that you have 10 to the power 4, like 10,000 cells in the body. So perhaps that's not a cure. So perhaps only time would tell whether this patient, despite MRD negativity, that we are really getting a cure of the disease. And there are just now, Ashif gave an excellent view of different methods. I'm going to bore you with all this. Suffice it to say that in general, you have two lines of investigation. One is a cell-based assessment, which is flow cytometry, and the other is molecular-based, RNA and DNA. That has been covered in the previous talks. Right. And again, likewise, that there are guidelines nowadays about how we're going to monitor this patient after 2 courses of induction chemotherapy, followed by every 3 months after the patient achieved complete 4 doses of hydroxychloroquine, for example. And then there are also about prognostication of post-ven AZA and how we're going to monitor this patient. Perhaps there are people who advocate every 3 months, during the treatment to make sure the patient get persistent MRD negativity. But all about post-transplantation, there's been relatively less information about how we're going to monitor this patient. So in Hong Kong, we actually had a kind of retrospective clinical studies in which we want to ask the questions whether day 30 post-transplantation MRD positivity, negativity, would that give us a clue as to whether the patient will relapse or not? And the reason being that you do it early in time, in post-transplantation, you will have ample of time in terms of manipulation by various, immune manipulation or FLT3 inhibitors, so on and so forth. Whereas patients who are negative, you may not want to do anything because you're worried about aggravation of graft versus host disease. So our study is pretty much based on the diagnostic NGS result. We designed, because we don't, up to this moment, we do not have flow cytometry MRD for myeloid diseases in Hong Kong. So therefore, we resort to molecular means, all right? And as you know that although NPM1 is one of the standard, but there are other non-NPM1 subtype AML, which we really have to have a handle of it. So based on the diagnostic NGS, we developed kind of personalized digital PCR protocol to answer the questions of whether the PCR could actually help us to predict outcome on day 30 post-transplantation. So here are the demographics of this patient. We altogether recruited 160 patients, and about, as you can see, that about 56% of these patients are male, and the others 44% are male. And then the age is 20 to 67, and then there's a wide range of presenting white cell count, and blast count likewise is 14 to 90 to 98%. We focus on mutation. Therefore, it's not surprising to see that we have an overrepresentation of normal karyotype AML. Normally, you would expect like half of this patient with normal karyotype, but in this cohort, we have about 80% of this patient have normal karyotype. And based on the year-end prognostication, about 1/3 of these patients are in favorable, intermediate, and adverse risk group. And in fact, 70% of these patients actually had this. All of these patients have CR1, have complete remission at transplantation. Among them, 70% of this patient was in CR1 at the time of transplantation. The other was in CR2 and CR3. 2/3 of this patient received myeloablative transplantation, whereas the 1/3 received non-myeloablative or reduced intensity regimen. And the types of donors were listed all in there. Okay, and in fact, there's a bit of a typo. In fact, there's number of tests that we did over there instead of number of patients, and altogether we did 250 MRD tests, all at day 30 post-transplantation, one time point to see what we can guess from the outcome. All right, and it's not surprising that among the 245 tests, 70 of them actually were NPM1 type 1, type A. But in addition, there are a list of other mutations, and that we did design digital PCR platform for them to see, as a handle of MRD. And in the bottom of it is that we have quite a number of tests that we did for CBP alpha. It just happened that we have quite a number of these patients. Somehow at various stages, they had the transplantation. So therefore, we developed digital PCR for them as a handle. And the MDS-related genes are a bunch of, spliceosome and STAC2, so on and so forth. The next one for this particular purpose. So here is an encore plot and telling us about. It's a very busy slide, but just to tell us, and the top of it, we had status at transplantation, donor type, conditioning regimen, the year-end prognostication, and the cellular genetics, and the list of various gene mutation. And the bottom of it, I want you to take note of it. So in some patients, we actually did multiple markers for individual patient, but all of them would have the marker 1, which is the first markers that we did, and the pink, the one in purple are the one who are MRD positive on day 30. The one in blue are the one who are MRD negative on day 30. Right? But there are marker 2 and marker 3. You can see that some of them are positive for one marker, but negative for the other marker, so on and so forth. So whichever they have a positive marker, we define them as MRD positive case. And you can see overall, these patients is at various complete remission stage, and they have a median survival of a leukemia-free survival of about 50% long term, and then likewise, so overall survival about 50%. This is the overall result. So as you can see that, it's not so surprising to say that patients who receive myeloablative conditioning, you get more of the patients who achieve MRD negativity on day 30, which is not surprising at all, isn't it? Whereas those patients who reduce intensity conditioning, more of these patients are MRD positive on day 30. Again, this is not surprising at all. This is what we would expect. If you get more intensive conditioning regimen, you get a higher chance of getting into MRD negativity on day 30. And here is an overall, take into consideration of all the markers that we use, that you can see that on the right upper is a leukemia-free survival. And those who are MRD positive are in blue. That means that they have a lower kind of leukemia-free survival post-transplantation if their MRD was positive on day 30. And the left upper and left lower is the overall survival. And again, it's statistically significant that the blue lines, which is MRD positive, all markers, not just NPM1, but all markers collectively, if you get MRD positivity, then you have a lower overall survival. And it's not surprising on the right lower that the incidence of relapse, cumulative incidence of relapse will be higher if they are day 30 positive post-transplantation. So this is everyone. We did a split of the NPM1 type A. Let's see. It's not moving somehow. Can I have the next? Okay, there we go. So therefore, if you do a splitting, these are the patients who are NPM1 type A. All right, and the separation between the mutant and wild type and the positive and negative one in terms of the leukemia-free survival and the incidence of relapse are much wider. That means that the NPM1 type A had a more predictive, kind of association on day 30 post-transplantation, and that can predict, in fact, like 20 years we are talking about in terms of overall leukemia-free survival and cumulative incidence of relapse. How about a non-NPM1 type A case? In fact, we also saw a difference in terms of the leukemia-free survival and the cumulative incidence of relapse. Although this is a miscellaneous group of patients with various mutations. All of them are not NPM1 type A mutation, but they could have different, CBP alpha, DNMT3A, all together because of number of issues that we put them together and make an analysis and show that in fact they were also predictive. But this is, there's a limitation of it. These are very heterogeneous group of patients. So we did a bit of correlation as to what may determine. Just now we talked about, patients who receive myeloablative conditioning, you have a higher chance of getting MRD negativity on day 30. And we put everything together, all the parameters together, and show that in fact it is only the MRD day 30 positivity that determines the outcome in both univariate and multivariate analysis. All the other one, they cancel out. But the day 30 MRD positivity is important in determining the outcome of this patient. And this is the final slide. I think the whole purpose of this study is to say that now that if day 30 can determine outcome, you have lots of time to do something to prevent the eventual, relapse post-transplantation, which once they relapse, options will be very limited. Just now we talked about FLT3 inhibitors, but in practical terms, we all of us would do in terms of patients who are at risk of relapse, we taper off the immunosuppression earlier. We give HMA, maybe we give DRI, and also FLT3 inhibitors, and just now we talked about IDH inhibitors, so on and so forth. So hopefully, on the time of day 30, we can, once we have the result, we can, we should do, number one, we should do it, and number two, we should act on it. Right? That's the whole point of the study, and hopefully by then, less of the patient will get relapse post-transplantation. I think this is the final slide. Thank you very much.
So MRD is useful in 3 phases. It's useful during, the organisers for inviting me to speak in this forum, and I'm sorry I wasn't able to be there in person. I'm going to be speaking about molecular MRD and with a particular focus on FLT3 ITD MRD. These are my disclosures. This is the way that I conceptualize MRD during the course of the patient's treatment journey in acute myeloid leukemia. So MRD is useful in 3 phases. It's useful during first-line therapy as a prognostic tool. In some cases, it can help select patients for transplant, but in general, it's very prognostic. For patients who are in remission, MRD can be used to monitor in remission to identify molecular relapse, which if identified correctly, portends overt relapse and allows an opportunity for preemptive therapy. And finally, before and after allogeneic transplant, MRD is incredibly prognostic and it can be used to direct the transplant and post-transplant management. There are many different technologies to do MRD with. We're going to talk about FLT3 ITD mostly today, and that's mostly useful during first-line therapy and pre and post-transplant. The monitoring and remission part is not quite as well established for FLT3 ITD. FLT3 ITD was previously said to be not a good MRD marker, and that's certainly what I was told when I was training. This was because it's a late mutation in leukemogenesis and can be unstable. It can change, can appear or be lost at relapse, especially if you give FLT3 inhibitors. So it was thought that monitoring for FLT3 wouldn't be useful because you might miss FLT3 wild-type relapses. As well as that, it was challenging. Doing it with qPCR, which is how we do many molecular markers, requires patient-specific primers because there's so much heterogeneity in the ITDs. And using NGS was challenging because the ITD can make the amplicon too long to align and properly detect. However, these problems have been overcome with what we call PCR NGS techniques. These involve PCR of exons 14 and 15 of the FLT3 gene and deep sequencing to over 1 million reads, and then specialized bioinformatics to align these to the reference genome and call ITDs. This is a very useful technique. It's very sensitive, down to 10 to the minus 5 or 10 to the minus 6, and doesn't require a diagnostic sample. You don't need to know what the ITD was. It'll pick up any ITD regardless of whether it's present at diagnosis or not. Additionally, it's a DNA-based assay, which is very useful because that's more stable than RNA. FLT3 was traditionally detected by PCR by electrophoresis, and this, as we all know, has a limit of detection of only around 1%. This is not a useful MRD technology. This is for detecting FLT3 at diagnosis. This uses PCR to amplify exons 14 and 15, and then capillary electrophoresis to detect the longer ITD fragment. And then, as discussed, the NGS-based technologies for MRD utilize PCR to amplify the exons 14 and 15, high depth sequencing, and then bioinformatics. This is from the Get ITD platform, which is one of many open source platforms that are available, but the techniques are similar between different technologies. And there's now a number of data sets that show that FLT3 ITD MRD can be very useful for prognosticating patients during frontline therapy who are being treated intensively for FLT3 mutant AML. On the left is the Quantum First study, which randomized patients to 7+3 plus or minus quizartinib, and patients who were MRD negative had much better overall survival than those MRD positive. The bottom left is a small study from Australia randomizing the addition of sorafenib, and again showing MRD negativity was very prognostic. In the middle is from the AMLSG 1610 study where midostaurin was added to chemotherapy for older patients. Patients who were MRD positive had higher relapse rates. And finally, a HOVON study without FLT3 inhibitors where patients with detectable FLT3 ITD MRD after induction in the marrow had relapse rates of 75%. So clearly, after induction therapy, the detection of residual ITDs portends high relapse and poor prognosis. The area where this has perhaps the largest body of evidence is prior to transplant. On the right is the same HOVON paper showing that patients who had detectable ITD MRD before transplant again had high relapse rate, with curves that mirror very closely the middle, which is the pre-measure study from the CIBMTR in the States using peripheral blood NGS MRD. The pre-measure study, or its subsequent study known as remeasure, showed in the top left that the burden of ITD was very important. So each of those curves is a higher amount of ITD detectable by the NGS, showing that patients with high-level MRD greater than 1% did really poorly, but even those with very low level down to 10 to the minus 6, which are the curves, the second and third curves, still had higher relapse rate. And this goes to show that no level of FLT3 ITD is safe. On the bottom left is a UK-Australian collaboration, which shows a similar thing, which is that high-level MRD prior to transplant is very bad, but even low-level increases relapse and worsens survival. I was asked to talk about the interplay between NPM1 MRD and FLT3 MRD. As we all know, NPM1 is the most common co-mutation in FLT3 ITD mutant AML. Around 55% of FLT3 mutant patients also have an NPM1. So the question is, if you have access to NPM1 MRD, do you also need FLT3 ITD MRD? And if you have access to both, which one should you do? There's a little bit of data from the NPM1 MRD, as we all know, is extremely prognostic, particularly in the blood. These are some of the older papers that demonstrated this, and this is equally the case for patients who have NPM1 AML with a FLT3 ITD. There are a few data sets that looked at the interaction between the two of them, and I've pulled out the numbers just to demonstrate how many patients are negative and positive by both assays. So the AMLSG 1610 study used NPM1 in the blood by qPCR, so the sort of standard way to do it, and FLT3 in the marrow. A little asterisk here, this is a FLT3 assay that's not quite as sensitive as many of the others. It's really only down to 0.01%. What they showed, as you can see in the table on the top right, is if you were negative by peripheral blood NPM1, there were no patients positive by FLT3. Conversely, if you were positive in the blood for NPM1, most of those were also many of those were negative for FLT3, but a few were positive for FLT3. So what this is suggesting is that NPM1 is a more sensitive assay, and as well as that's earlier in leukemia mutation, and so will often be positive when the FLT3 is lost. This is backed up by data from the HOVON study. In this case, they'd done NPM1 and FLT3 both in the marrow, both with a similar NGS assay, and the NPM1 FLT3 assays were similarly sensitive. And this showed a similar finding. If the NPM1 is negative, it's very uncommon for FLT3 to be detectable. So there's only 3 out of 70 cases of marrow NPM1 negativity who had a positive FLT3. Whereas if the NPM1 was positive, around half were positive for FLT3 and half were negative. So again, the NPM1 is, when it's negative, almost always the FLT3 also is. And finally, from the pre-measure study, using blood, again using NGS for both NPM1 and FLT3, found a very similar finding, but even more striking. So if your peripheral blood NPM1 was undetectable, the FLT3 didn't add a lot, with only 2 of 268 patients being detectable by FLT3. Whereas if your NPM1 was positive, then the FLT3 was useful, and around half of those were positive by FLT3, and the patients who were positive by both did the worst. So taking all this together, I think if you've only got one test, the NPM1 is probably the more useful one in general, as it's more sensitive and it's more stable in the leukemic cells. But both are useful, and the FLT3-ITD does give you some extra information in the patients who have detectable NPM1. So patients who are positive for both do very poorly, whereas those that are positive for only one have an intermediate prognosis. And FLT3 is the marker where any detection is bad, whereas NPM1, you can have low-level bone marrow NPM1, and that's not so bad. However, the big caveat to this, and I'm sure people will talk about this, is there are defined scenarios where FLT3 MRD is especially important, and that's particularly pre-allogeneic transplant for selecting patients for maintenance therapy. Finally, I was asked to discuss real-world experience of FLT3-ITD MRD, and there's not a lot published in the literature. There are a couple of studies on the left using qPCR for FLT3 and on the right using NGS that show, as you would expect, detectable or high-level MRD for FLT3-ITD after induction is very bad. There is one paper, this one from Oduro in Modern Pathology, which went back and pulled out old samples for patients who had subsequently relapsed and tested them by FLT3-ITD MRD. So this is a way of analysing whether monitoring in remission, which we discussed at the start, would potentially be useful with FLT3-ITD MRD. And the fourth column is the one of interest here, which shows for patients who relapsed, on the pre-relapse sample, could you detect the FLT3-ITD? And in the vast majority, you can. There was only 4 that you couldn't, but the sample that they had was 3, 21, 6, and 9 months prior, so not really an immediately prior sample. So this is perhaps a suggestion that monitoring in remission might be useful, and we're building more evidence for this. So that's all I'm going to...
Okay, thanks to both speakers, and now we're going to take questions, and we will begin with one question from our virtual audience in Russia, followed by a question from the room. And there are present no questions on.
It's a question from Russia team. As the FLT3s can disappear with relapse, especially after FLT3 inhibitor therapy, is it necessary to control MRD using another method, flow cytometry, for example, and NPM, if it's possible? Thank you.
So let me just clarify that I understand the question. If you have a FLT3 patient, but you do not have a FLT3-ITD MRD, can you use flow or NPM1 to monitor? Is that the question?
Yes, because we know that after FLT3 inhibitor therapy in relapse, we can see the relapse without FLT3.
Oh, so in other words, loss of the FLT3 mutation is MRD monitoring of use?
Yes, yes.
Okay. Well, I suppose you can offer. So the incidence, I can comment on the incidence of loss of FLT3 mutation in the Morphos study. Surprisingly, it was not that common. We were expecting it. We did not have many samples that we could sequence for mutation at relapse. And only about a third of the relapses on gilteritinib were FLT3 negative. So there were other resistance mechanisms at play. That said, I would advocate for using every possible means of monitoring. If the patient has an NPM1, you should use NPM1. If the patient has a FLT3 and you have access to the assay, you should use that. By all means, we are not yet ready to abandon flow cytometry if you can identify relapse that way. I think the broad message is never trust AML. It will always do the unexpected. Dr. Bajaj.
Nothing more. I'll just say that it really depends on what the clones are there and what the other co-mutations are there. But as we are using targeted therapies and we're using selection pressures, you're quite right. AML can escape, and so use all techniques that you can potentially use and targets that you can potentially use. I'm just going to hand over to Dr. Ansgar.
Agree completely.
Yeah, my question is for Professor Liang, SCA. And thank you for your sharing very important finding, the post-transplant, day 30 post-transplant predict outcome. My question is regarding which predictor is most important, pre-transplant or post-transplant, or you combine both into consideration?
Thank you very much. As you probably know, that this is a retrospective study. So basically, we get all of whatever samples we are available to do the studies, in fact. So in Hong Kong, we receive patients from all over the territory for bone marrow transplantation. Very often they have the transplant, they have the marrow done to show morphologic remission and refer to us. So we may not have, in all of them, we may not really have the pre-transplantation kind of molecular MRD in that sense, but we do have day 30. And for that reason, we actually chose the day 30 because we have the sample to answer that questions. But I would agree with you that, both pre and post will be important, though that, at the present moment, like whether it's pre or post, it doesn't really affect the intervention very much. Maybe prognostication, but eventually, be it MRD positive or negative, we still go ahead for the transplantation. So, but whereas post day 30, post BMT, if MRD positive, we have a lot of things to do to make sure that patient wouldn't relapse, hematologically.
Yeah, my second question is regarding the different types of MPL mutation. In your study, you show the type A mutation have a more predictive power. As to my knowledge, most patients have a type A instead of type B or type D. Do you think the result is due to the selection bias or inadequate patient number or any biology reason to explain the different treatment outcome?
Right. Well, type A definitely will be prognostic, as you can see. I mean, both from us and from other studies, post-transplantation, the curve are widely separated. And we deliberately removed the type A and to see what happened to the other types, which is a miscellaneous group of patients. Each of them contribute a few of these cases. So I think the case number is an issue. We did demonstrate the kind of a difference in the two curves in non-NPM1 type A mutation, but the curves are not that widely separated. I think for that reason, I think one of the is about the sample size. This is one issue. For individual cases, we actually make use of that to guide the management in terms of we had this will be in the session 2 perhaps that we have individual patients where we have a positive marker for CBP alpha digital PCR, and then we did something in terms of HMA and so on that bring it down. So I think it's still prognostic, but whether to answer the question is as robust as the type A mutation NPM1, we have to have a larger number of cases to demonstrate this.
So I think we're going to wrap up this session. So if your question has not been addressed in this session, please submit it via the Slido QR code, and we'll get to it in session 2. So I want to now hand things over to Professor Jianxing Wang to chair the next part.
Okay, thank you, Mark. So next part we will focus on
Incredibly prognostic and it can be used to direct the transplant and post-transplant.
Okay, thank you, Mark. Next part we will focus on selecting suitable MRD assay, also validate MRD as a clinical marker for the clinical outcome. So first I will share my all experience in my institution. So 2 speakers follow on. Okay, so today I will share my experience from my institution. I come from Institute of Hematology and that belong to the Peking Union Medical College. So how to check molecular MRD in our institution? Let me say, this is my disclosures. This is the outline for my presentation, focus on the method we use for MRD assay, also how to define the cutoff value to determine MRD positive or negative. And then followed by, after MRD assay, we should do the risk adjustment based on MRD assay. And then we will talk about transplant based on MRD levels. And finally, during monitoring, we'll see observe the MRD occurrence that is associated with outcome. You will see a result. So, first of all, for the MRD method we use three approach. One is the most used for maybe for every patient use a multicolor flow cytometry, but for some specific fusion genes such as AML, CBF beta, and APL mutation, we used acute PCR routinely. Just recently, we set up the NGS method to determine some mutation also for phase 3 RTD. For the MRD assay use, flow cytometry is relatively widely used. We don't have the specific marker for the MRD, but for this assay, usually we use 2 tubes. Use multicolors. It's relatively easy. A patient will draw fluorescent laboratory, they can do the assay. So there are 2 approaches for the multicolor assay. One is use LRP. That means leukemia-associated immunophenotype. And that really depends on the phenotype at diagnosis. At diagnosis, we recognize the immunophenotype after get remission and we send a sample for MRD. Based on this immunophenotype, we can determine how many leukemia cells can be detected, or negative or positive. But you should be noticed during the chemotherapy, something can occur. Some leukemia cell can lose antigen or the antigen shift. So that means the immunophenotype may be changed during treatment. So this is a shortage for this method. So another way to overcome this disadvantage, use the DFN. That means differentiate from normal. Really, that don't depend on the immunophenotype and the diagnosis. Really depend on the deficient pattern to recognize leukemia cells. But they have some disadvantage for this. Really, they're depending on the personnel. Really get real training, have good skill. They can recognize the leukemia cell, but its own. Another thing that should be noticed for the immunophenotype MRD assay, due to in some case, so for example, the immature monocyte looks this kind of the immune monocyte sometimes is difficult to recognize by immunophenotype. So for this assay, I think during this the flow cytometry, also most of them can be detected. Another approach, I think, we just set up for NGS just recently. So they have 10 genes can be detected. Due to this very limited gene mutation can be detected, that means after the library construction, we can read more sequence. That means we can have very high sensitivity to detect this mutation. However, due to this sequence, the false positive can be occur. But for this positivity, for sensitivity at 10 to the -4, so they are very low false positive, they can be used. Another approach just recently we set up for the phase 3 RTD. Just the mark-based our institutes also has experience, say, oh, this is really good method. So recently we just set up the phase 3 RTD mutation analysis. This is an example for 2 cases shows NGS method. For one case, you can see, oh, this is the 2 cases for the NGS. For one case, you can see all the mutation can join simultaneously, but for second case, you can see don't parallel drop down. So that means in this case, you can show really for during the MRD monitoring, so they have the several clone occur together. We should pay notice that in the highest clone, we should pay attention to that. So next we determine a threshold for cutoff value. For year-end method, for flow cytometry, use 0.1. But how about in our laboratory, whole institution, what is the limited detection? We had defined 3 levels. One, we at least for analysis 0.5 milli. Another is 0.1, less than 0.1. Once the leukemia cell can be detected, although it's less than 0.1, also associated with a higher relapse rate. These are quite different from year-end criteria. Even after cycle 2, same pattern. But for the fusion gene, also after ROC analysis, we define 0.1 as the cut value for this fusion gene. Also, for the risk defined by MRD analysis, you can see what occurred. So this is for after cycle 1. If the leukemia cell can be detected for intermediate risk and high risk and adverse group, you can see once a leukemia cell can be detected, associated high relapse rate. Also, that is translated worse over survival. However, for favorable risk group after cycle 1, they have the MRD level have no influence. But for the cycle 2, there's something changed. Even for a favorable risk group, after detected MRD, really can cause increase or relapse and translate to worse over survival. However, for adverse group, you can find that doesn't matter whether or not MRD positive or negative. That almost all patients have very high relapse rate. But pay attention to for the favorable and intermediate risk group, once MRD become negative, really associated with the very relatively become same. Intermediate risk and favorable risk become very good survival. However, even for a favorable and intermediate risk group, once MRD become positive, they have similar pattern as adverse group. After that, we can get the risk adjustment after MRD, especially for the after cycle 2. For favorable and intermediate risk group, once it can become MRD positive, we can adjust this group to adverse group. However, once all patients with the favorable and intermediate risk group MRD positive negative, we think this patient belong to the favorable group. However, for the adverse risk group, doesn't matter MRD negative or positive, still regarded as an adverse group. There's no change. But also, I think the MRD level is really have the impact on transplant. If you look at the intermediate for the favorable group, so the MRD negative doesn't matter, it not get beneficial from transplant. However, after cycle 2, even in the favorable group, MRD positive, this patient really through transplant can prolong the overall survival. However, in the intermediate risk group, cycle 1, cycle 2, they become MRD negative. Also, there are no impact. Transplant don't have impact on overall survival. However, or after this is after cycle 2, even cycle 1, the MRD positive. Also, this kind of patient can get benefit from the transplant. However, but in addition, pay attention to the adverse group, cycle 1, cycle 2, MRD negative or positive. Transplant all give the beneficial to this group patient. So, of course, for the patient after get remission, we should still give the monitor patient very closely through the MRD analysis. Also, the MRD analysis, we use multicolor cytometry. Really, once the MRD become positive, really the relapse rate increased dramatically. Also, that translated very poor relapse-free survival and overall survival. That means once we detected MRD positive, we should regard the patient as a morphology relapse. Some people will be asked, what is the blood number, high or low? That is related to relapse rate or not? In fact, once we detected multicolor, even 1 cell or 2 cells, very high, low levels, so they have same pattern as the blood number is high. So that means, although this method not quite sensitive, once detected, we should treat it as early as possible. Yeah. We divided the patient into favorable, intermediate risk, and adverse risk group. Also monitor MRD. Once the patient occurred, the MRD reoccur. So that really associated with a higher relapse rate. So doesn't matter year in genetic risk group. We should very closely monitor MRD during the follow-up. Yeah, the summary. So multicolor is widely used and mostly is suitable for us. MRD, especially for cycle 2, may be quite important to make decision. Also make adjustment of the risk. Also MRD recurrence, also we think is a very good, is a high risk associated with high relapse rate. We should making a rapid decision to intervene and prevent morphology relapse. Thank you. Yes, thank you. And now I would like to invite the Dr. Kim from Korea to present his experience from his institution.
Okay, I'm from Seoul St. Mary's Hospital, Catholic University of South Korea. So I'd like to introduce the experience from my institution. So this is my disclosure. So you know very well the relapse refractory FLT3 mutated AML patients are very rapidly changing field. So I'd like to present some old and new data from my institution. Previously, we analyzed the patients who received a second allotransplantation after relapse by any kind of mutation groups. So include these FLT3 mutations. So as you can see this slide, some portion of patients who are received a second transplantation after relapse, any kind of approach is not that good. So they showed only less than 5% long-term survival rate, including FLT3 mutated AML. But recently, according to the Admire trial, the relapse refractory FLT3 mutated AML patients enrolled in the world. So among the trial, 6 patients in my institution also. Okay. 6 patients enrolled in this trial. Among this, 1 patient, a 62-year-old male patient, normal karyotype, NPM1 negative, primary refractory to the intensive chemotherapy, 14% blast pre-transplant and underwent unrelated donor transplantation with reduced intensive conditioning. And unfortunately, he received a maintenance but only 1 year due to hypertension. I don't know the reason why, but anyway, they have to quit the maintenance after 1 year. But fortunately, he developed acute and chronic mild form of GVHD, and he alive in continuous CR over 5 years without relapse. This is a big change compared to previous our experience. There's no good choice, no good results for this kind of specific case anyway. And according to our institution's analysis, this portion of patients, the low panel, the right panel low portion, the very big hurdle, as I mentioned, the TP53 mutation, MECOM rearrangement, monosomal karyotype, complex karyotype, something that showed only less than 3 to 5% long-term survival rate. So I'd like to briefly introduce the history of development of the FLT3 analysis. As you mentioned earlier, the PCR electrophoresis, the quite the conventional method, detected the FLT3 mutation quite a decade ago. And then we analyzed our patients who relapsed refractory after intensive chemotherapy and transplantation. 4 serial cases showing various type of FLT3 activity mutation. Among these, only 1 patient showed a very repeated multi-clone mutation. We reported this case in 2005 leukemia. And then thereafter, the quantitative fragment analysis of FLT3 mutation, very advanced techniques. So this report adopted by the NCCN guideline a couple of years ago. Anyway, this is a very good example of the analysis of FLT3 mutation in our institution. And then we, as you repeatedly demonstrated today, is a pre and post peri-transplant monitoring should be possibly predictable to the level of the FLT3 mutation status. So 40 patients in our institution also analyzed the pre and post-transplantation status of the FLT3 mutation, so we can trace up the FLT3 level very precisely. And most recently, our institution also developed the PCR NGS, but was a little bit different from other forms. NGS seed algorithmic technique. Briefly, these techniques to repeatedly compare the original sequence with randomly inserted seed sequence, so we can chase up the specific NGS, specific FLT3 mutated sequence very accurately. So the detection level is around 10 to the minus 6. So this form, from our laboratory medicine, is a quite representative form. The report the chromosome abnormality and the FLT3 status at the initial diagnosis, and follow up with the NGS and the explanation anyway. So that's bottom line. You can see the FLT3 ITD mutation from right to left, from negative, positive, and negative again. And come together with donor chimerism, also can find a complete chimerism. There's no change, but there's a little change of the FLT3 ITD mutation status. And together with the flow MRD status from right to left, you can chase the minimal level difference. Anyway, this 5.2 to 8% means a very impending relapse status. And nowadays, as I mentioned, the PCR-seed, the more precise technique showing like these results, the FLT3 ITD PCR positive chromosome regional location and BAF ratio and base pair also reported together. Okay, so I'd like to briefly present my case. 25-year-old very young female patient diagnosed as AML from the tertiary university hospital in Seoul, Korea, referred to our hospital due to primary refractory disease state after 2 cycles of induction, reinduction, as mean the intensive chemotherapy failed. So, but according to the medical record, her initial diagnosis, there's no FLT3 ITD mutation. And bone marrow aspiration biopsy performed in our institution at like this, 40 and 50% celerity with greater than 20% blasts. Cytogenetics showed inversion for mosaicism. And she received the second reinduction chemotherapy from our institution. But at the time, we found that the new clone, FLT3 ITD, positivity reported again, initial negative, but again positive. The report showing 3%. The BAF ratio, allele ratio very low, but 65 base pairs are a little bit longer base pair. And uninterestingly, there's another clone, 3% allele ratio, but 79 base pair, 2 different clones that are present together. And she received gilteritinib, fortunately, but after completion of 2 cycles, the partial control, and in January 2022, she received the allogeneic transplantation from a younger brother, 24-year-old male. Pre-transplant status was FLT3 still FLT3 positive. The BAF ratio a little bit higher than before, and still there's 2 clones, 65 and 79 base pair, and persistent MRD status. So, and after transplantation on 1 month, still positive. But interestingly, the 79 base pair disappeared, gone, and only 1 single 65 base pair clones remained. And the follow-up of bone marrow after 3 months, March 2022, FLT3 ITD positive, but BAF ratio very much increased, 40%, allele ratio is still the same 65 base pair. So this case is very unfortunate. Then we have no choice at the time, so she received a gilteritinib again, and then together with the DLI, the 1, 2, 3 cycles. During those times, we followed the bone marrow studies with the FLT3 mutation status. So still FLT3 ITD positive with the same 65 base pair 1, the pre and post transplantation, still the same clones are remainder. And the pre-transplant, the bone marrow finding is also a little bit decreased. BAF ratio is 8.6%, a little ratio 6.5 same, but no good alternative donor choice at the time. So she received finally the umbilical cord blood transplantation, and immediate and received a transplantation. But at the time, she suffered very much this kind of whole kinds of post-transplant complications, so she had to be admitted for more than 7 months. Anyway, she overcome all kinds of this complication at the time, a little bit decreased the pulmonary functions instead. And most recently, just before this meeting, she's still alive 3 years, 4 months after umbilical cord blood transplantation, and she's very well. As you know, the 25, 26-year young female patients also active and recovering well due to the good rehabilitation support and the complete continuous remission status with good performance. She's a banker. She's returned to her occupational job again. Okay, as you can see, this bottom table, we can follow up her FLT3 TKD and FLT3 ITD status, and you can see there's a good example that in the middle, the little bit higher level of the WT1 flow and FLT3 ITD mutation, positive and negative conversion after umbilical cord blood transplantation. And this year, the last follow-up of bone marrow also showed the negative FLT3 ITD, so it's a very good example. So in conclusion, these patients with extremely high risk AML was able to achieve durable remission with ongoing complete CR, continuous complete CR, and reasonably good quality of life. Key success factors could be effective salvage with gilteritinib plus DL, but I'm not sure whether DL has any kind of a role, but anyway, we experienced this case. So successful engraftment with immune reconstitution of umbilical cord blood. As you know, umbilical cord blood second transplantation is not that easy, say anyway. Aggressive infection control and good supportive care for more than 7 months hospitalization, we can overcome this hard situation. And with good support from the rehabilitation medicine and psychological recovery could be the multi-factor to get this successful story. Okay, thank you.
Okay, thanks, Professor Kim. So next we have maybe a last speaker for this session 1. Professor Livas again will discuss the whole MRD relapse, may redefine what we consider it as relapse refractory AML.
Okay, here we go again. Starting with a case. So this is a case that we're gonna talk about for the next 20 minutes on and off, just one case. And it started a long time ago, 6 years ago. 61-year-old man, he has diagnosed with AML, again, 6 years ago, pretty much this month. And molecular studies, he had a trisomy 8, FLT3 ITD, 57 base pair. Look at the VAF, only 1%. CBP alpha, NPM1, PTPN 11. Okay. So he got 7 and 3 midostaurin, got a complete remission, and PCR. Now, this is 2019. We were developing the MRD assay at this time. I could only use it in sort of research instances at the time of this diagnosis. So he came to me for allo transplant, or actually I was following him. We then used his nephew, I think, and we did the Hopkins post-transplant PSI, which is what we were giving for everybody there. So he's in complete remission. Now, a wise leukemia doctor always told me there's nothing complete about a complete remission. Again, a bone marrow that's in remission is kind of like a calm sea. It looks very peaceful, but you don't know what's beneath the surface. And so this whole concept of MRD, everybody shows this graph again. I always think of it as a deep lake. And there's unreliably detectable disease, but somewhere swimming around down there is what I call the monster. And will we let him come to the surface? We can sometimes, literally in my patients, watch it rising, which is reasonably scary. So for this patient, we were reminded of the general pattern of pathogenesis, a founder, a cooperating mutation, and a signaling mutation. And in fact, that's kind of what he's got up there. He's, there's our FLT3 ITD. Now about this 1%, Professor Kim just showed you agarose gels, because back 20 years ago, that's what we used to identify these things. Right now, you're all using a capillary gel electrophoresis method, but agarose gels was how we used to detect this disease. And you heard from Dr. Othman earlier today that when he was growing up in hematology, we learned that FLT3 mutations were unstable. You couldn't use them for MRD. So this is a study, and I actually, this was from 25 years ago. I'm afraid I was one of the reviewers for blood for this study. And this looked at patients with this mysterious new mutation, FLT3 ITDs, at diagnosis. And you can see they reported that some of these patients at diagnosis, they were negative and positive at relapse. They were using that agarose gel system. So my patient that I just showed you with 1% VAF, he's negative. He comes up as 0 in this study, guaranteed. Here we go again. And some patients actually lost, supposedly had it and lost it. And so this work 25 years ago put in everybody's mind that these mutations are unstable. But you have to understand how we detect these mutations and the flaw that is in the basic assay that we all use. So here we have a medieval molecular pathologist preparing to do a FLT3 ITD assay. And so I'm going to show you how we actually do the assay. And this is, I think, is important. Remember, so here we have the FLT3 receptor. We have crystal structure, and we know that the mutations are found in this juxtamembrane domain. It has an auto-inhibitory function. And the TKD mutations are found in the so-called activation loop. So here's the cDNA for FLT3, the kinase domain. And the juxtamembrane domain, we're going to, by a slippage repair mechanism, we think, results in this duplicated segment. So that's what we have to detect, the presence of that. It's normal sequence and a variable length. And that's the other interesting point about this. The point mutations clear out there. So these are different ITD mutations. Look at all of them, different lengths. Each one is like a fingerprint for the patient. So this is actually beautifully made for MRD. You don't need to do sequence-specific primers. The specific mutation length is a fingerprint for the patient's disease. Uh-oh, we're not advancing now. You can do it. There we go. So here is the PCR method that most people are using around the world. Most of these patients present heterozygous, one mutant, one wild type. You put primers down, flanking the juxtamembrane region, and you go back and forth with PCR cycles. But you'll note the mutant is longer and amplifies less efficiently. So in a capillary electrophoresis system and using this PCR reaction, if you take a pure population, one mutant, one wild type, and do, say, 28 cycles of PCR, you still don't get equal peaks because you do not amplify the mutant as efficiently. Oh dear, the host would like me to unmute. So if somebody wants me to stop talking. All right, so 35 cycles, it gets even worse. There we go. So actually going back again, no. So 35 cycles you can see, and this is what, there we go. Well, 45. So I'm trying to go backwards here. Let's try this. There we go. So 28 cycles, you get nearly equal peaks, even though there's an equal amount entered. If you try and increase the sensitivity of the assay, let's increase number of cycles. it gets worse, you actually get more competition from wild type. And if you try and crank up the number of cycles to 45, even worse. And now, suppose you have a much longer ITD, 90 base pair. Okay, this is a really big template bias. And even a pure population of 1 mutant, 1 wild type will give you a wildly inaccurate VAF. This is one of the reasons I don't use VAF in my decision of whether or not there's an ITD there. It's there or it's not. If you can detect it, it's there. There's a lot of flaws in the assay and its sensitivity. So this is called template bias, and it's a flaw, and it keeps the sensitivity of this conventional PCR assay at 1%. You're not going to get lower than that. So we've been talking about this PCR NGS assay, and we call it that because you put in DNA into a tube, you need enough DNA. An MRD assay of 1 cell is not an MRD assay. You need lots of cells. 100,000 cells is about 500 to 700 nanograms of DNA. You put that in, you do that exact PCR assay I just showed you. And we use 25 cycles. That gets you a bunch of amplicons. You clean that up with a bead system. Now I have a test tube with 1 million juxtamembrane amplicons, just those. How do I detect my ITD? Well, you just walk that on over to your next generation sequencing machine. It can pick out the ITD sequence in those 1 million amplicons. And it generates a number. Suppose it finds 3. So that's 3 out of 1 million. 3 times 10 to the minus 6. That's the artificial number that it comes up with. You put in, I didn't put in 1 million cells. I put in 100,000 cells worth. But that's where these numbers come from. And so we know ELN recommendation using any method of MRD, if you see an increase, that's sort of the equivalent of relapse, right? So we ran this Morpho study using this assay. And the Morpho study enrolled everybody all over the world, and it was asked the question, does post-transplant gilteritinib help prevent relapse, prolong survival? And we used that MRD assay throughout that entire trial. Now, giving a FLT3 inhibitor after transplant does lead to some toxicity. It leads to some myelosuppression and increased GVH. We did see this. And we saw, okay, the trial was negative by a whisker. Patients, though, who were MRD positive immediately pre or post clearly benefited from the drug. Patients who did not have MRD didn't benefit. So, furthermore, the assay turned out to be incredibly quantitative, just like a ladder. Having no MRD in blue is better than having an MRD to the minus 6, which is better than MRD minus 5 and MRD to 10 to the minus 4. Or for the over on the right there, the relapse risk, it goes up just like a ladder. Incredibly quantitative. The amount makes a difference. And there is simply no level that is safe. Every level was associated with an increased risk of relapse, and every level, gilteritinib lowered that relapse risk. So the targeted therapy worked on the target. So everything made sense here. So that's where we're coming up with the concept. There is no safe level. And we followed the kinetics of relapse, of course. Each line is a relapse. And these are patients that have detectable disease after the transplant. And you can see everything's happening very rapidly. Look, in the first basically 6 months, if anything, even the first 4 months, blown up here in the placebo arm, either the clone is getting cleared with the allogeneic effect or the patient's rapidly relapsing. Over on the gilteritinib arm, mostly it's clearing. But you do see some patients where there's persistent disease either way. And it's a minority, but they're there. And here is an example of one of them. This patient here got her transplant. She had 3 clones, and 1 was still detectable right after the transplant. Patient goes on gilteritinib maintenance, and we know the patient was compliant because we actually had PK. And yet this red clone, this 30 base pair, is still there. But the patient is blinded to that, the physician is blinded to that, and per protocol, the patient must stop the therapy at 2 years. The shark is still there. And the study drug is stopped. Patient immediately relapsed with the exact same 30 base pair ITD. So you can spot these patients. You have time. The patient should never have stopped gilteritinib, obviously. And in fact, here is where you'd want to do something to eradicate that clone. So getting back to my guy, we're going to now look at his VAFs. I'm going to trace you out over the last 5 years for him, what his little story has been. So his diagnosed here, and here he gets his induction and high-dose cytarabine with midostaurin, by the way. He got his transplant here, way back when. Okay, I started him on gilteritinib at 120 per day. This is back when I was still doling out the full dose, and my nurse practitioner was yelling at me because it would cause their counts to drop. So we do 80 now. And he got GVHD, skin, mucocutaneous. It wasn't terrible. So I did actually dose reduce him. And again, I've gone over this before. Hematopoiesis, I kind of showed this where you have this FLT3 stimulation, increasing Tregs and suppressing GVH, and the opposite occurring with FLT3 inhibition. So he's getting some GVH. Okay, that's all right. And I also showed this where, again, the only study that didn't show increased GVH didn't give the drug very long, any FLT3 inhibitor. So what I did with him is I decreased him to gilteritinib 80 per day. Now, I still haven't looked at a MRD because I'm trying to get the assay where I can send it. And he's on 80 of gilt, and I finally get my first MRD assay. Oh no, there's his 57 base pair ITD. It's not very high, 7.5 times 10 to the minus 6. And this is, again, this was 4.5 years ago. I hadn't really learned what was going on with these mutations. So, all right, increase to 120. Let's try that. And by the way, give DLI. Why not? Let's try some DLI. Oh, look, it worked. His VAF dropped to undetectable. Aren't I great? So unfortunately, as a result of that, now I have chronic graft versus host disease. He's getting some squamous cell carcinomas. Great. Okay. And by the way, he got histoplasmosis along with his GVHD. So he was getting sick from all that I did to him to try and make that thing go down. Oops. All right. Well, he actually I had to treat him, and he went off. So he had to get POSA and some steroids. And so he was actually off gilteritinib. Boom, comes right back. Oh dear, what do I do now? Okay, well, go back on your gilteritinib. All right. Oh, look, it makes it go away again. That's good. Okay, things are calming down. Oh no, he got RSV pneumonitis. He's hospitalized. He's at like some outside ski resort hospital. It was pretty bad. And they stopped his gilteritinib. I said, that's fine. You got to get better. He was MRD negative. He'd been MRD negative, look, for over a year. I thought maybe I was okay. Okay, so we resumed. Oh dear, the thing promptly came back. He's off gilteritinib. That's bad. So I put him back on it. Now, I just got an MRD assay on him about a week and a half ago. It hasn't come back yet. I have no idea what it's going to be at. And just for good measure, I did check NPM1. It's the same. It tracks exactly identically in this. So what am I going to do with this guy now? There's my life right now. I have no idea what to do with this guy. If it's rising, I'm probably going to hit him with the triple. As I said, it's time for the azaven gilt. But this is an important new tool, as I hope I've shown you. It allows clinicians to monitor the disease. It does give you time to act. Changes. The big problem I've found of the multi-clonal disease, these single clones you can manage. The changes in the level essentially define disease relapse per ELN. And there is no safe level. There's no single approach to treating this disease, as I hope I've shown you. Different patients, different versions of the disease, and you pretty much have to use all the tools you have and do the best you can. And we will, there's Watson and the shark. They're attempting to fend off the monster as it's rising. We use anything we can to hurl at the monster. And I'll stop there. Thank you.
Okay, thank you, Mark, again. So the two presentation is afternoon, also address many questions. So for this part of our session, we will take questions first. I will take questions from the virtual, from, I think, supposed to be from Saudi Arabia or UAE. Yes.
We are facing a lot of now resistant to the FLT3 inhibitors. One of them is the presence of the multi-clone, and it's been already elaborated by the presenters. And those patients with co-mutation, especially with RAS mutation. So my question, we know them that first of all, they did not achieve deep remission before the transplant. And even those patients, when they transplant them, they relapse early. So is the changes of the FLT3 inhibitors between the FLT3 inhibitors can overcome this resistance? Or we have something different that we have to anticipate different thing post-transplant to overcome this highly risk of relapse. The second question regarding the use of gilteritinib, that we know post-transplant it will increase the GVL effect, and by that it will increase the GVHD. So when you will stop the FLT3 inhibitors post-transplant in a patient who had active GVHD, and how safe to restart when they are a little bit on lesser dose of immunosuppression?
Goodness. For the first question, what do you do with these mechanisms of resistance, multiclonal and RAS? First of all, try and avoid relapse or refractory states. So in other words, that's why obviously your best therapy needs to be moved up front. But I have had to deal with multiclonal disease. I don't have a good answer. I have tried switching to quiz. It doesn't work. There is a fundamental level of resistance in this multiclonality that we don't understand. I raised the issue a year ago with that publication, really to kind of wave my arms in asking for the community help. Here's a new scary subtype of FLT3. I don't know what to do about it. It's not responding to the usual treatments. I don't know whether they're going to, I have tried DLI. I have tried switching FLT3 inhibitors. I have tried the triple aza-ven-gilt. It didn't work. So I'm not sure what to do about multiclonal disease at this time. RAS, tricky. There is a pan-RAS inhibitor that Kathy Smith is working on. I think maybe that's going to be the answer for the RAS mechanism of resistance. I don't know. And the second question was, oops, what was the
GVH after GVH?
Oh, yes.
You should
So
stop.
that happens to me all the time. You have to use the MRD assay if they're negative, much like I just showed in this patient. Patient's got GVH, I've got to stop the drug. I then follow them closely, but you'll note I had time. It didn't rocket up and relapse instantly. He was like, oh, it's back to 10 to the minus 6. I've got to put you back on. You can try a lower dose. I've not found the lower doses keep the clones contained. Unfortunately, I got to do a minimum of 80. I don't find 40 works. So.
Can I ask you, Mark, how frequently do you monitor once you stop?
So you can do peripheral blood, which is tenfold less sensitive. So I tend to prefer doing a single aspirate first pull. I don't do a core. I don't do flow. I only want 2 slides and my MRD assay, a couple cc's, and I tend to do it every 3 months.
Yeah, so okay, maybe we should stop here. So thank all the faculty members. Also, very good discussion, very good presentation. Next, we have 15 minutes coffee break. So after the coffee break, we have this MRD forum move to the session 2. That will divide it 2 groups. Group 1 stay in the ballroom, and group 2 move to the studio 1.